कल दिवाली, many time Diwali is on 2 days,
Yeah,
आज है कल
yes.
है.
यस यस,
हम्म।
आज तो यहाँ पे तो होलिका
कब
दहन
शुरू
है.
करें मोनिका मैम?
यस
हाँ हाँ
6 तो
बिल्कुल,
हो
श्योर
गया
श्योर.
है,
हाँ
क्या करें?
यस.
हाँ, प्लीज स्टार्ट. कोरोना पीपल प्लीज
Are
स्टार्ट.
we live? Mani, we can just start it. Yeah. Warm welcome to all of you. A very happy Holi to all of you. I welcome all of you to this 222nd edition of the Happy Learning Masterclass webinar series. This one is being conducted in association with Amritsar, Chandigarh, Faridkot, Firozpur, and Patiala societies. And a very, very important theme, that is PPH. It's a nightmare for anybody and everybody, of course. So before starting the webinar, I the things not a if you can could please have the landing.
Hello.
Yes.
Good evening, respective faculties. My name is Rakesh Kumar Behra. So, on the behalf of Corona Remedies Limited, so I welcome you to this respective Happy Learning Masterclass webinar series. So, here I am going to handing over this webinar session to Dr. Shatabdi. So, ma'am, over to you. So, you can continue the sessions. So, I'll be there for you. If anything is required, do let me know.
Okay. Okay.
Over to you,
So
ma'am.
a warm welcome again to all. Warm welcome again to all of you to this 222nd episode of the Happy Learning Masterclass series.
Dr. Shatabdi, we can't hear you. I think आपका there is some network error there.
I think Shatabdi has logged out. She
हाँ.
might be logging in again. Meanwhile, we can have the blessings
The
of the
prayer,
Almighty.
हाँ,
We
prayer
can have
song
that.
कर दीजिए.
Prayer song बना दीजिए. Meanwhile, she is joining again. Mr. Rakesh?
Yes, ma'am. Yes.
हाँ, please. Prayer song लगा दीजिए. We will have Almighty's blessings. चलो चल रहा है ना. Dr. Shatabdi, are you going to start?
Dr. Shatabdi is not there, I think.
Okay. Then I will start
आप
with the
करो, हाँ.
program. हाँ.
आप start करो, Dr. Monica.
Happy Holi, everyone. Good evening and welcome to the 202nd episode of Happy Learning series. And today we are going to talk about the very important, very common, even though we know everything, but still we lack somewhere and we are losing the mothers because of PPH. Without wasting much of the time, I welcome all and request MC Patel sir to give some highlight on this program and welcome the chief guest for their blessings. Over to you.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all to 222 episode of Happy Learning Masterclass web series. And today joining society Amritsar, Chandigarh, Faridkot, Firozpur, and Patiala. I welcome Chief Guest Dr. Ashish Sarin Madam and Dr. Madhu Nagpal Madam. They both have kindly consented to be Chief Guest to bless the webinar. Welcome, Madam. I also welcome Guest of Honor Dr. Kala Vasist Madam, Dr. Parinit Kaur Madam, Dr. Umesh Jindal Madam, and Dr. Amritpal Kaur Madam. They have kindly consented to be Guest of Honor to bless the webinar. I also welcome all the chairpersons who are going to chair very respective session. Dr. Sarabjit Kaur from Firozpur, Dr. Monica Narang for Jirkapur, Dr. Preet Kanwal Sibia Madam from Patiala, and they are going to chair very interesting session which is going to be delivered by Dr. Deepa Goyal Madam from Patiala, and she is going to talk about medical management of PPH. Same way, one more set of chairpersons, Dr. Renu Chakravarti Madam from Panchkula, Rimi Singla Madam from Mohali, and Rasmi Bagga Madam from, again, President Northern Indian Society. And they are going to chair very interesting session of stepwise devascularization, and it is to be covered by none other than Dr. Lakbir Dhaliwal Madam. I also welcome one more set of chairpersons, Dr. Yash Bala Madam from Panchkula, Dr. Manjit Kaur Mohi Madam from Patiala, and Jagjit Singh from Faridkot. They are going to chair interesting session of legal issues in obstetric hemorrhage, which will be covered by me only. And very interesting panel as far as management of PPH is concerned and troubleshooting in management of PPH is concerned. Case-based discussion by two learned moderator, Dr. Vinit Nagpal and Dr. Natasha Gupta, and with expert comments from Riti Mehra Madam from Chandigarh and Alka Sehgal Madam from Chandigarh. They are going to put their expert comments during panel discussion. And learned panelist, Dr. Dinesh Pathak from Firozpur, Dr. Sangeeta Pahwa Madam from Amritsar, Dr. Preeti Jindal from Mohali, Dr. Bharti Goyal Madam from Chandigarh, Japlin Kaur from Chandigarh, Dr. Anupam Goyal from Chandigarh, Manisha Jain from Chandigarh, and Meenakshi Rohila Madam from EC Secretary Northern Indian OBGYN Society, Ruchi Rai Ahuja Madam from Chandigarh, and Mangla Dogra Madam, again, she is one of the panelists. So when this series we started in era of COVID-19, where physical meetings were not possible, and we started to meet our Foxian friends on this virtual ground and to discuss focused topic, just like we are going to discuss PPH today. And our goal was to brush up our knowledge and to be helpful to check maternal mortality, which is prime concern as an obstetrician. Because by 2030, government and WHO has given us a target, maternal mortality rate should be less than 70. And there are so many states, even on today, they have reached this goal and they are nearby 30 or some 40, 50, 53 or so. But at the same time, few are the states still having maternal mortality near 200. And that is why it becomes a matter of worry. And it is a joint venture on part of government, organization like IMA, Foxy, and our all Foxian friends, particularly who are working in rural India, and they are much more concerned with this topic and with this episode of PPH. And that is why we are much more concerned with this topic, and that is why we have kept this topic for today's discussion. But before I go further, I would like to mention role of all my team, convener Dr. Monica Umardan, and coordinator Monica Gupta, Satabdi, Dr. Nivedita, Dr. Lugani Madam, and Dr. Megha Kamlapurkar. And at the same time, I would like to put it on record efforts and help by Dr. Vineet Nagpal, not only drafting this webinar, but from drafting to execution of this webinar, she was with me and she has helped me a lot. Of course, she is always with me whenever I have called her as far as any academic activity is concerned. So thank you, Vineet, for the same. And without wasting much of your time, welcoming you all the president and secretary of respective society who have joined this webinar today, and all the delegates and guests. Thanking you again. Thanks very much.
Thank you.
Thank you, sir.
Shatabdi,
Thank you, sir. Yes, ma'am. Yes, ma'am, I'm there. Yeah. Thank you, sir. Once again, thanks to the Amritsar, Chandigarh, Faridkot, Firozpur, and Patiala societies. Thank you, MC sir, for this for your words of wisdom. I would now like to welcome Dr. Vineet Nagpal, ma'am. Ma'am, as sir said, has been instrumental in coordinating this program. She's designed the whole program and helped sir design this thing very nicely. So, ma'am is a senior gynecologist, and she's worked with the Punjab government for more than 25 years. She's presently a senior consultant at Landmark Hospital at Chandigarh and formerly was the assistant director in the Department of Health and Family Welfare, Punjab. She is an expert member, yes, of the Punjab State Supervisory Board of the PCP and DT government. Welcome, Vineet, ma'am. I would like you to kindly introduce our chief guests, Dr. Ashi Sareen, ma'am, and Professor Dr. Madhu Nagpal, ma'am.
Sir, it has always been a pleasure working with sir, because sir's one phone call is all that matters, and we start in Punjab as soon as sir calls. तो सर का हुक्म सर आंखों पे रहता है हमेशा.
Hello.
It is my very, very proud privilege, and I'm so much honored that I am introducing the chief guest for today, the person who is actually teacher of teachers. And I was her intern, and I was doing MBBS in Patiala, and she's none other than Dr. Ashi Sareen, ma'am. She needs no introduction, and she has been instrumental in starting the Patiala Society, Patiala Obs and Gynae Society. So can I have the CVs also, so that everybody can view, ma'am? Like, she's like a gem. So can I have formally the
Rakesh,
slide?
can you move the CVs, please? Next, please.
Next, please. Next. Yeah.
Next
one.
Next.
Click. Yeah,
That
go on.
everybody can have a look at her.
Yes,
because
We will just keep
Thank-
moving.
Since decades, she is into gynae.
Keep moving, please. Next.
Next slide, please,
Next, आप
Rakesh
next पे आ जाओ.
ji.
बस यहीं पे रुक जाइए. Yeah, Dr. Vineet. Yeah.
Ma'am is formerly, currently she is a consultant at Astha Medical Center, Patiala. So welcome so much, ma'am. And it was just a phone call that you accepted this invite. I'm so much grateful. And the second chief guest, can you please move the slide?
First, let's have ma'am's blessings, Dr. Nagpal.
Ashi Sareen, ma'am, please, kind words from you. I'm a very, very old and very young student of yours, ma'am.
I'm so happy to be here. And this is a very important subject and one of the important causes of maternal mortality. And if we can reduce PPH and timely intervention is the key to management. I think all the delegates will benefit from this talk. Thank you.
Thank you. Thank you so much, ma'am, for the blessings and kind words, ma'am.
Thank you, madam, for sparing time for us to bless us.
Most welcome. I'm so happy to be here.
Thank you, madam.
The second chief guest is none other than another iconic personality of Punjab, that is Professor Dr. Madhu Nagpal. She is ex-professor and head GMC Amritsar, and she headed the SGRD Amritsar as well. And she graduated from the same institute. And she has 42 years of academic teaching experience to her credit, and her interests are, of course, medical teaching, practical obstetrics, and conception. And she is regional faculty for certificate courses on GDM, contraception, and she has published over 105 papers, unique case reports, regional and national journals. And she is also ex-president of Amritsar Obs and Gynae Society, chairperson, speaker, panelist in international, national, zonal, and regional CMEs, and a life member of our FOXY. And she's on the editorial board of 2 journals and peer reviewer for journals of repute. Thank you so much, ma'am, for being here. And ma'am, blessings and kind words from your side also, ma'am. Madhu Nagpal, ma'am. As she joins, Monica, ma'am.
I think ma'am has not yet joined. So whenever ma'am joins, we will take her blessings at that
Sure.
time.
So,
So we should go to the guest of honors now.
Yes,
thank you.
I think
Yes, ma'am. Yes, ma'am.
Dr. Monica, आप
हाँ,
start करो. हाँ जी.
we have got 4 guests of honor today. Dr. Kala Vashisht Madam, Dr. Parneet Kaur Ma'am, Dr. Umesh Jindal Madam, and Dr. Amritpal Kaur Dhillon Ma'am. Please put the CVs.
Yeah.
Dr. Kala Vashisht Madam, she is a very, very senior gynecologist. Even before many of us were born, she has done the training of OBGY from Bangkok, Thailand in 1967 to 73 from Jakarta, Indonesia. She is a postgraduate professor and head of department PGIMS Rohtak, principal investigator of multiple funded projects on high-risk pregnancy at PGIMER, Chandigarh, and she's a member of many society, and she was a joint secretary FOXY and a life member of many societies. Over to you, ma'am, for your blessings. I think madam has not joined. Kala ma'am has not joined. And she has got enormous publications and written the paper and attended the guest lectures. Whenever madam joins, we will have her blessings. Dr. Vineet, madam has not joined, no? I couldn't see her.
मैम नहीं दिख तो नहीं रही है.
हाँ,
उमेश
नहीं
मैम
दिख-
is there, I think. Yeah.
And next,
आप
please.
next पे आ जाओ. हाँ जी.
Next, Dr. Parneet Kaur ma'am, she is a professor and HOD from GMC Patiala, having a teaching experience of 29 years. She is an examiner of undergraduate and postgraduate students for last 16 years. She has got 75 publications in various national and international journals, contributed 4 chapters in the book You Are 3 reputed specialty general, and she is a secretary of Punjab chapter of NIGF. Over to you, madam, for your blessings. Paneet Kaur ma'am, she's there.
Good
ma'am.
evening, ma'am.
Ah.
Good evening.
Good evening, ma'am.
Ah.
Mr. Patel, sir, for picking up this very important topic, and my best wishes for the webinar, and regards for all the senior faculty and my dear.
Thank you, ma'am.
I think madam का net में कुछ
Network,
problem
हाँ.
आ गई
Ma'am
है.
has given her blessings.
Ma'am, Paneet ma'am, whenever her net will be connected, we can have the remaining blessings. Yes, ma'am, please. Ma'am, please continue.
Yeah, good evening, everyone.
Yes, ma'am.
Best wishes for the webinar, and thank you, MC Patel, sir, for picking up this very important topic of PPH. My best wishes for the webinar and all the senior faculty and my dear colleagues who have joined.
Thank you,
Thank-
ma'am. Thank you,
thank you
madam,
very-
for sparing time.
Thank you very much, ma'am, to be with us in our webinar series. Next,
Yes.
Dr. Umesh Jindal ma'am, she's a director of Jindal IVF and Sant Memorial Nursing Home, Chandigarh. She's a former assistant professor, PGIMER, Chandigarh, and she's a former fellow of University of Washington, Seattle, and RAS, Kansas City, USA. She's a pioneer in ART in Chandigarh, and she's having a 22 years of vast experience in IVF, and she was the first to start IVF, ICSI, Vertification and PGT in Chandigarh and Northern region. She is a vice president of Indian Fertility Society of North India. Over to you, madam, for your blessings.
You have called me as a guest of honor, but I think I have come here as a student, and not so closely working in obstetric unit, although we are doing obstetrics. So whenever occasionally we come across PPH, it's all a mess. So I've come here as a student, and it's really very, very important topic, Dr. Patel, you have chosen, and congratulations for that.
Thank you, madam.
Thank you, ma'am. It's your humbleness to say कि you are a student, but we know you are the teacher of teachers. Next, please. Dr. Amrit Pal Kaur Dhillon, madam. She is a president of Amritsar OBGY Society, and she has got a vast experience of working in the field of OBGY Society. And over to you, madam, for your blessings.
So, very good evening to all my seniors and dear colleagues. I extend my sincere thanks to Dr. M.C. Patel for organizing this webinar and bringing all our colleagues from Punjab and Chandigarh on one platform. My special regards to our teacher, our chief guest of the day, Dr. Ashish Suri, who was the head of the department when we were doing MBBS. So, ma'am was the senior most professor of head of the department and a very good teacher at our times. So the topic chosen by Dr. M.C. Patel is very important, very relevant in the current scenario. And we all have to join our hands for fighting towards the preventable causes of PPH, the biggest killer of the mothers when we do day-to-day practice. And many a times we call Dr. Patel when we are handling the challenging cases of MTP, especially MTP, we can't make a decision. And we call, and she is just a call away and always been helpful in helping us out in the difficult cases, especially. So, sir, we are there with you, and we extend our best wishes for your candidature here and for the upcoming election. And we assure you full help and full nomination. And last time also we nominated you and tried our best, but somehow it's always a game. And this time we assure you and extend our best wishes from the entire society. But one thing we suggest you plan a physical CME with Amritsar to get the blessings from Golden Temple.
It is in pipeline.
You see many of the previous presidents of FOXI, like Dr. Madhuri Patel, Dr. Sunita, Dr. Jaideep Tank, Dr. Narendra, Jaideep Malhotra, and many others, they visited Amritsar and they started this journey from here only. So I request you plan sometime for Amritsar also, and that will be a great episode with all of us. Thank you and wishing you all the very best for the upcoming elections and best successful webinar of the year. Thank you, sir.
Thank you, madam.
Thank you, madam, for your kind wishes. And before concluding the inaugural program, I just request everyone कि MC Patel sir is going for the president election this year, and we all should vote and support for him. And I request everyone to put their full effort to convert into the voting. And now I hand over.
Thank you, Monica ma'am. I'm extremely sorry for joining late today. We thank our chief guest, Dr. Asha ma'am and Dr. Madhu, and our guest of honor, Dr. Kala, Dr. Paneet ma'am, Dr. Umesh and Dr. Amritpal ma'am for joining us today. Wishing sir all the very best for all his future endeavors in FOXI and as a presidential candidate for the year 2026, requesting all these societies to please vote and support the candidature for Dr. M.C. Patel, sir. Sir, with your kind permission, can we start with the academic session, sir?
Oh, yes.
Deepika ma'am, over to you.
So thank you so much. And good evening to all our esteemed faculty and all the delegates who are watching the webinar. And at the outset, I wish to thank Dr. M.C. Patel sir and Dr. Monica for giving me the opportunity. And now we start with our scientific session, session 1, which is on the medical management of PPH. And it is my honor to start by introducing the chairpersons for this session. The first chairperson is Dr. Sarbjeet Kaur. Can we have her CV, please? Yes. So, ma'am is the secretary of Firozpur Obs and Gynae Society of Punjab under Foxy. She has previously worked as registrar at Lilavati Hospital, Mumbai, and has been in private practice for the past 12 years with a special interest in high risk obstetric cases. Madam is known for her dedicated clinical commitment and sincere contribution to women's healthcare in her region. Welcome, ma'am. Can we have the next CV, please? Our second chairperson for this session is Dr. Monica Narang. Madam is the director of Blessing Hospital, Zirakpur at Punjab, and is a senior visiting consultant at the Alchemist Group of Hospitals. With over 15 years of experience in high-risk obstetric practice, her special areas of interest include gynae, laparoscopy, and cosmetology. And she's the founder member of Association of Panchkula Obs and Gynae Society. Welcome, ma'am, for our webinar. Can we have the next CV, please? And our third chairperson for the session is Dr. Preet Kamal Sibia, ma'am. Madam is a professor in the Department of Obs and Gynae at Government Medical College, Patiala. Ma'am brings over 20 years of teaching experience and serves as an undergraduate and postgraduate examiner with more than 50 publications in national and international journals. Ma'am is also the secretary of the NABA Obs and Gynae Society. We welcome our esteemed chairpersons. And could I ask my chairpersons to introduce our speaker for the session, for the first session? Has any of the chairpersons logged in right now? Dr. Monica, can you see?
Good evening, everyone. Myself, Dr. Preet Kamal from
Good
Patiala.
evening, ma'am. Yes, ma'am. Please, can
Good
you
evening,
introduce
everybody.
yes, could you introduce Dr. Deepa Goyal, madam?
Yeah, sure.
Yes.
Ma'am is from Patiala only, so
Yes.
we are honored to have her on this webinar.
Please,
And
can we have her CV, please? Yeah. Yes, ma'am. Please, Dr.
Yeah. She's a graduate from PGI Rohtak and MD she did from PGI Chandigarh. And she's past president of Patiala Obs and Gynae Society. And she's a member of Rotary International Appreciation Award she got for her commitment. And she's a very well-known and intelligent gynecologist of Patiala. We welcome you, ma'am. Over to you, ma'am.
So, Dr. Deepa Goyal, ma'am, the stage is all yours. And ma'am is going to speak on medical management of PPH. That is a topic.
Can I share my slides?
Yes, ma'am. Mr. Rakesh, please stop sharing. Yes.
Good afternoon, everyone. At the onset, I'm thankful to the organizing committee, especially Dr. Patel and Vineet, who have given me a chance to speak on a very important topic, postpartum hemorrhage. Why are we discussing it today? Because there have been recent guidelines.
Ma'am, please ma'am, excuse me, can you make this full screen? Yeah, abhi we can see the left side पे आपकी slides. आप मैम full screen पे चले जाइए. Slide show कर.
Unmute. Okay.
Yes, ma'am.
Is it okay now?
मैम उसको क्लिक करिए. हाँ, अब ठीक आ गया मैम. Yes, ma'am. Thank you. Please go ahead.
So why are we discussing this topic today is because there have been in October 2025, there has been updated guidelines by WHO and FIGO, and which of course we know that how to treat, we know the drugs which are available, but how to use them, what is the protocol, and that is what is important. So at the time of emergency, we do not do any hodgepodge and treat the patient as per the protocols. So this is what is now consolidated guidelines for the prevention, diagnosis, and treatment of postpartum hemorrhage by FIGO and WHO, which are in use. They are available on the website and anybody can see them and anybody can read them. But why was a need for these? What was the need for the consolidated guidelines? It is to unify 15 years of scattered recommendations here and there. This guideline has 51 consolidated recommendations which across prevention, diagnosis, and treatment. It emphasizes evidence-based and well-adaptable protocols. So, actually, what is the global burden of the postpartum hemorrhage? If you can see this picture, then there are 14 million women who experience PPH, leading to 70,000 deaths, accounting for nearly 27% of maternal deaths globally. So, which is a huge number. So, I think that is why the reason why we are having these guidelines, that is called emotive. We will discuss them one by one, but early detection, a team-based care, a standardized treatment, continuous monitoring, and also the emotional support to the women is very important. So what is the incidence? We all know vaginal delivery around 4%, cesarean 6%, rural areas approximately double. This is because of the lack of the skilled health workers as well as also the infrastructure, and maternal mortality, as we have already discussed, around 27%. So what is the change in the updated guidelines? Previously, it was just blood loss of more than 500 cc. But now it says blood loss of more than 300 cc with any other warning signs. What are the warning signs? Pulse more than 100, systolic BP less than 100, diastolic BP less than 100. Most important is the shock index. If shock index is more than 1, then you are heading for a disaster. And what is shock index? Shock index is pulse rate divided by systolic blood pressure. If you also see the warning signs like a rapid blood flow, large clots, or anemia, then also you take action if there is a blood loss of 300 cc, or as previously blood loss of more than 500 cc, or the clinical judgment. So this is one place where WHO has changed the recommendations. So I think what is most important is prevention and the early diagnosis of postpartum hemorrhage. And this is something which we all need to do in our labor rooms. This is what is called the module 2 of WHO and FIGO recommendations. So what does it involve? It involves 3 things: giving a uterotonic within 1 minute of the delivery of the last baby, they say. That means if they are twins, the delivery of the second twin, then cord cutting, and then cord traction. We will take all these one by one. Which uterotonics can we use? Oxytocin 10 international units intramuscular or IV, or carbetocin heat stable 100 microgram intramuscular or IV, or misoprostol 400 to 600 microgram orally. Now coming on to the oxytocin, I think this is the drug which we have all used in our times. And probably I don't know how effective it was, how many people put this oxytocin in the refrigerator. Whenever it is there, usually you find it in the wards, in the labor rooms, without being refrigerated. And probably that decreases the efficacy of oxytocin. So I think it is very important that it should be refrigerated. How is it given? If it is to be given intramuscularly, then you can give stat dose, or it is diluted and given IV slowly over 1 to 2 minutes. What is carbetocin and heat stable carbetocin? This heat stable carbetocin does not require refrigeration. It is 100 microgram 1 cc. It can be given intramuscular or IV. But if you have to administer it IV, then administer very slowly over 1 month. And till date, it is used only for prevention of PPH. If you are not using heat stable carbetocin, then you have to place the carbetocin also in the refrigerator. One point here, why is it only for prevention of PPH? why not for the treatment of PPH? Well, till now, no studies have found its efficacy in treatment of PPH, but WHO is conducting a trial with the name of the REACH trial. And maybe in 3 years or 5 years, this may be also useful for the treatment of PPH. Third drug, which is very useful nowadays and which we are using a lot, is misoprostol. 400 to 600 microgram orally or sublingually or per rectum. No refrigeration is required. Only thing is it has to be protected from humidity. This can be used both for prevention and treatment. So suppose there is a high risk patient and to prevent PPH, you want to use 2 drugs. You can do it, but then seeing the pharmacology of all these, you should combine oxytocin with misoprostol. Why? Because oxytocin and carbetocin, they act on the same receptors of the smooth muscles. These are G protein coupled receptors. So if you use oxytocin and carbetocin, so there's no synergistic action at all. Rather, your carbetocin might be less effective if you're using oxytocin because there will be no receptors left on the myometrial smooth muscle for carbetocin to be effective. While on the other hand, misoprostol acts on different receptors. It acts on EP3 receptors of the smooth muscle, which releases intracellular calcium. So when you use it with oxytocin, it has a synergistic action. So in case there is a high risk patient, for prevention, you can use these 2. Now, what not to use? I think that is also very important, what not to use. And what does these current guidelines say? Ergometrin, methyl ergometrin is not recommended for the prevention of postpartum hemorrhage. Fixed dose combinations of oxytocin and ergometrin is not recommended for the prevention of postpartum hemorrhage. Injectable prostaglandins are not recommended for the prevention of postpartum hemorrhage. So please make a point here that what to be used and what not to be used. So we were talking of giving uterotonic within 1 minute, and we have discussed what all we can keep. At the same time, we should keep a performer with us, and we should assess and record the uterine tone, blood loss and flow, BP and pulse every 15 minutes. After giving the uterotonic, you have to start measuring the blood loss. Cut the cord between 1 to 3 minutes. It is recommended 1 to 3 minutes because especially if there is no bleeding and the baby doesn't have any fetal distress, because it helps combating anemia in the neonate, and perform the controlled cord traction for the delivery of the placenta. Controlled cord traction should be performed only by a skilled health worker. At this moment after the delivery, one should be very alert for PPH. We will go further, and this is the 2 other things: cut the cord and perform controlled contraction. I think for this August gathering of obstetrician, I don't need to explain how it is done, though just to mention a few points that controlled cord traction should be done only by a skilled health worker. It should be done only during contraction. If there is any resistance is felt, one should leave it. The other very important thing now is that you should prevent infections. Whenever you are conducting a delivery, wash your hands, wear sterile gloves, wear apron, mask, eye shield. To protect the baby, always wear double gloves before birth and remove the soiled pair before clamping and cutting the cord, and properly dispose of all the contaminated supplies and equipment as per the protocol. So this was all about the prevention. But now you are in a situation where there is placenta is not out even after 30 minutes, or there are some retained fragments. What to do? You have to remove it manually after 30 minutes. The time period now is 30 minutes because we have practiced the active management in the third stage of labor. Again, I am not going into this detail of how to remove the placenta because I think the gathering there, they must have done it umpteen numbers of time. But if somebody wants, it is there in the guidelines. Now, after removing the placenta, amount of blood loss will depend on how quickly the placenta separates, how effective is the uterine muscle contraction around the placental bed, and what about the intact coagulation symptom. In the meantime, we have put this calibrated drape for objective assessment of blood. This is something which has now been recommended in the guidelines. This is the kind of the drape which is now available. Its price is not much. It is around 70 to 80 rupees. And it has two lines, one at 300 and one at 500. So there is a warning yellow line at 300 and there is an action line at 500. But to be honest, though I have used it, many times we are losing more blood than what is collected in this drape. So don't always depend on the collection in the drape. We all know now that the patient is bleeding. It is more than 300. The 4 T's of the causes of bleeding, we all know: tone, tissue, trauma, and thrombin. And out of this tone, 70%, 20% trauma, 10%, and thrombin, 1%. So now you have to start with the PPH bundle. What is WHO first response bundle? This is called E-motive. What is this E for? E is for early detection and trigger criteria, which we have already discussed. The M starts for massage, O for oxytocin, T for tranexamic acid, I for IV line, and E both for examination and escalate care if required. So massage the uterus first. If you are alone, then just concentrate of massage, call for help. A second health worker should always be there when you have started treating for a PPH. Massage of the uterus will cause contraction, expel blood and clots, assess for the distended bladder. If it is there, catheterize. If you are alone, I insist, massage first and then move on. All the other parts of the bundle should start simultaneously. Even if the patient responds to one measure, please continue with the other measures. But extra uretrotonics can be given. You can give oxytocin 10 IU IV diluted in 100 to 500 of crystalloid fluids as far as possible, or as a bolus over 1 to 2 minutes. If there is no IV line and there is no help, then give 10 units intramuscularly and misoprostol here 800. For prevention, we are giving 400 to 600. Second IV line, and we have already started oxytocin, maximum 60 IU in 24 hours. You can, here there is indication to give ergometry, 200 microgram, that is 0.2 milligram intravenous or intramuscular. This can be repeated every 4 hours up to 5 doses, and maximum in 24 hours is to be 1 milligram. You can use misoprostol here in the dose of 800 microgram sublingually. Tranexamic acid. this is something which has to be given. And how this has to be given? It has to be given 1 gram intravenous over 10 minutes. Faster administration can cause hypotension, and be careful that don't add to the same bag tranexamic acid and oxytocin, though the same line can be used. There are some precautions when you are giving tranexamic acid. If it is more than 3 hours since birth, then do not start tranexamic acid. Or if there is contraindication or hypersensitivity to tranexamic acid, known thromboembolic events, renal failure, or history of convulsion. How does tranexamic acid help? We all know that tranexamic acids prevent fibrinolysis, and thus clot is there, and that is going to stop the hemorrhage. But then why not after 3 hours? What happens that we do not give it after 3 hours of PPH? If we see how tranexamic acid acts, then initially it is prevent fibrinolysis. But if you are giving after 3 hours, not only in PPH, even in the cases where there is a traumatic acute trauma and all, they say it can cause paradoxical bleeding. And the other thing why we don't give is that within 3 hours, mostly either dilutional or consumption coagulopathy starts. And if you give tranexamic acid at that time, it can cause prothrombotic events. And there has been cases reported where a patient was being referred to a tertiary center with everything given, but on the emergency trolley during the transportation, somebody gave more tranexamic acid and the patient landed up in atrial thrombi. So it is a drug which is very useful, but it can itself cause bleeding and thrombi. So be careful when you give tranexamic acid. After we have done all this, we have a help and we have started the second line. The second line is important to start with the gray IV cannula, because it's a big cannula and we have collect that for hemoglobin lab testing and clotting studies. Now you have to examine for the cause. So we have done all this. We have done second IV line, we have given utrotonics, we have repeated TXA, and we are assess and record. I think this is what just now I said, that this is a FIGO recommendations that administration of tranexamic acid is soon, a diagnosis of PPH is made as long as this is within 3 hours postpartum. Suppose the bleeding continues after 30 minutes, you can repeat it. And if it restarts after 24 hours after the first dose, a second dose may be given, but nothing more than this. Now the bleeding didn't stop. It's kind of a refractory PPH. So you start blood transfusion. There is a complete protocol how to start blood transfusions. I cannot go into the details of those because that's going to take a bit time. You have to recheck the repair lacerations, apply bimanual and aortic compressions, insert uterine balloon tamponade, and if you think you need to refer, then you might put a non-pneumatic anti-shock garment. So there's a compressive measures, bimanual compression as well as aortic compression, intrauterine balloon tamponade, and non-pneumatic anti-shock garment. This I'm just trying to show. The first picture here is of the bimanual compression, which we are all used to. When the patient is bleeding, first give it at least for 5 minutes, then release and then see. If it starts bleeding again, then keep on repeating it. You should not leave the patient without the massage. Let the other health worker do the other things. Second is this aortic compression. This aortic compression has also been found to be very useful. It is given with a fist with thumb inside. Apply the pressure slightly towards the left and above the umbilicus. And with the other hand, you keep the palpating for the femoral pulse. If you cannot feel the femoral pulse, that means the pressure is adequate. Then now we are thinking that the bleeding has not stopped. What to do? So we can go in for uterine balloons, as this is a first surgical management. Though I know I am supposed to cover only the medical management, but I thought this is partly medical and partly surgical. So I'll cover this. So there are 3 types of balloons available: condom balloon, Bharat balloon, Chhattisgarh balloon, and of course the Bakri balloon, which was the first innovation. After that, as we are a country with low resources, so we know how to do jugaads. So we made a Bharat balloon. This balloon actually has made of medical grade silicone with a volume of 500 cc. It is cost reduced. It can be etio-sterilized. It takes the shape of the uterine cavity. It is compatible with the drip set and syringe both. The only disadvantage here is that it has no drainage system. If you can make Chhattisgarh balloon, this can be done at your own center. And I think for these you need some workshop where somebody can train. It is very easy to make. And I think at Patiala, most medical college residents, they know, and they can make this balloon very soon. We have had workshop at our societies twice to show how to make this balloon. Now, if the patient is still not controlled, what will you do? Now, after the balloon, if there is bleeding stops, but it is a temporary thing, it is not cured the bleeding. One has to be very watchful. So if your center has all other facilities and you want to transfer the patient, you can refer the patient, but with non-pneumatic anti-shock garment on. When you are putting in the balloon also, if you compress aorta, it will be easier for you to put in the balloon. And if you are repairing the laceration, if you have compressed the aorta, again, it is very easy to repair those laceration because the bleeding is minimal. So aortic compression is one good thing. So what about the non-pneumatic anti-shock garment? I'm sorry, I can't show you the video. I'm short of time here. So all I will say is it has 6 segments. Applying as well as removing has to be learned. The first 3 segments, they are on the leg. They should be applied by 2 persons, while the 4th, 5th, and 6th, they go up. So they can be applied by a single person, and to make sure that you don't apply too tight and the patient doesn't have any difficulty in breathing. While removing also, I think one has to start removing with the ankle segments, and after one segment is removed, wait for 15 minutes and check that the pulse doesn't increase by 20, systolic BP doesn't decrease. If vital remains stable, only then you should open the next segment and continue the same way with the remaining segments. So summary and takeaway, any women who is birthing can have PPH. So be prepared for PPH, whether it is low risk, whether there is no risk, or whether there is high risk. It is preventable. Use consistent protocol. Apply active management of labor with any of these uretrotonics. Motive bundle if PPH. Ensure tranexamic acid within 3 hours and maintain readiness. Uterine balloon tamponade, even suction cannulas like the Paniker's cannula, SR cannulas, they are being used. Though I didn't find any, I can't say that there are many publications on this suction cannula, but those who have used it, they claim that they act very well. Lab profile and blood transfusion, how to give blood transfusion, what to give blood components, in what order to give are very, very important. Follow the proper referral protocol, and when you are referring, please use non-pneumatic anti-shock garments. Thank you. And these are the forms, postpartum monitoring form. You must use them, because if you have a medical legal, your forms would be checked by everyone. So you have one paramedical staff who should be filling on all these forms. It says that you have to record every 15 minutes from birth for 1 hour. If by that time there is no bleeding, then you can start observing every half an hour for 2 hours, and then as per protocol. But if there is a PPH or any other high risk, you please keep on monitoring with this. And this is a PPH kit which should be used. These I'm showing just because if you have a medical legal, if you have the preparation for this kit, if you have these forms ready, if you can show that you had a balloon in your labor room, if you can show that you have this anti-shock garment in your labor room, you might be safe. I think more Dr. Patel will be discussing on the medical legal aspects of PPH. Thank you very much. I would be happy to answer any questions.
Thank you, ma'am.
Thank you, ma'am. Requesting the chairpersons to give their comment or speak a few words about the session before we move on to session 2.
Thank you, ma'am. Thank you for such an elaborative discussion and your views on the PPH. It is such an important topic, and I always say we should pray to the God to bless the treating doctors for PPH and also our patients. So, ma'am has very clearly mentioned all the medical management, the new guidelines, and a word about the balloon, which is very, very useful. And in our college, we are using it, and we are also calling seminars to treat the field doctors for this, which is very, very useful and life-saving for the PPH patients. And the most important, I just wanted to convey is that we should teach the field people that they should not waste the golden hour. That is the most important, because most of the times when the patient starts bleeding, they just refer the patient. They should start the medical management, and then accordingly they should refer at a proper time. Thank you, ma'am. Thank you so much.
I think I agree with you. First 20 minutes and the first hour. First 20
Yeah.
minutes, the chances of PPH are much more. So you should be very vigilant. And
Yes,
if
ma'am.
PPH occurs, the first hour is very important. And I think PPH workshops at various society level, at the civil hospital levels, from where the patients are referred, are very important. These are simple things, doesn't involve the surgery part or a real complex surgery. So I think this itself can, at least the patient can reach a referral center in a good condition.
Yeah, thank you, ma'am.
Now we will listen to the surgical management by surgeon par excellence, Dr. Dhaliwal. Thank you.
Thank you, ma'am, for the excellent deliberation on medical management of PPH with special reference to the E-motive. Moving on to session 2, we have, as ma'am has rightfully said, an excellent deliberation by a surgeon on the surgical stepwise devascularization. And to chair this fantastic session. We have three very eminent chairpersons, Dr. Renu Chakravarti Madam, Dr. Rimi Singla, and Dr. Rashmi Bagga. Dr. Renu Chakravarti Madam is a consultant obs and gynae at Chakravarti Nursing Home, Panchkula. She's been associated with Ministry of Health of Iran, where she's worked as a consultant in obs and gynae for 4 years. She's been the senior consultant in charge and HOD department of obs and gynae Chakravarti Nursing Home, heading Panchkula Obs and Gynae Society, associated with Haryana State and Health and Family Welfare Department for training medical officers and health workers for the last 10 years. Past convener and executive member of Chandigarh Obs and Gynae Society and life member of FOXY. The next chairperson for this session, Dr. Rimi Singla, is the director of Radiance Hospital and Test Tube Baby Clinic at Mohali. She is also the medical director of Singla Mediclinic in Laparoscopy, Fertility and Gynae World. She's the president of Mohali Obs and Gynae Society, treasurer of ISAR Chandigarh, founder secretary of Mohali Obs and Gynae Society, chairperson Disha Women's Welfare Trust, and member of Women's Wing IMA Chandigarh. A life member of number of organizations like FOXY, COGS, MOH, OGS, ISAR, IFS, IMS, and IMA. Faculty at various state and national conferences, and among a pioneer in the region to develop cosmetic gynae, especially starting PRP and stem cell therapy, with multiple awards, especially in the field of IVF, as well as awarded by His Excellency Shri VP Singh Badnor, Governor of Punjab, for services to childless couples on the occasion of official celebration of 150th birthday celebration of Mahatma Gandhi, 2018. She's also been awarded with the Disha Women's Award in 2018 by the Honorable Minister of Health and Family Welfare, Punjab, Shri Balbir Singh Sidhu. The third chairperson, Professor Rashmi Bagga, Madam, is a professor in the Department of Obs and Gynae in PGI MER Chandigarh. Her area of interest is gynae oncology, colposcopy, gestational trophoblastic diseases, high-risk pregnancy, and ultrasound-guided invasive procedures. She is the president of Northern India Society. I would request Dr. Renu Chakravarti, Madam, to please introduce the speaker for this session. Renu, ma'am, please unmute yourself, ma'am. Ma'am, you're muted. मैम अब अभी भी म्यूटेड है मैम.
It's okay. We can
Ma'am?
save time. We can save time.
Yeah, I think, yeah, okay, fine. I think we can please move on to the CV of Dr. Lagbir Dhaliwal. Tech support, please.
We
Yeah.
can omit that also.
No, she's a former professor, HOD Obs and Gynae at PGI MER, past president of Obs and Gynae Societies of North India, and former director WHO and ICMR Center for Research in Human Reproduction, with major contributions in established and advanced in fertility services at PGI MER. With lots of research, completed 80 projects funded by WHO, ICMR, DBT, DST. You can see the number of research products, number of research expertise ranks top 9% of authors worldwide. And she's presently the senior consultant at Fortis Hospital and Milan Fertility Center, Chandigarh. So I think she's one of the best persons to be speaking on the topic of stepwise devascularization for management of postpartum hemorrhage. Over to you, Lagbir ma'am.
Thank you, dear. Thank you. Kindly stop sharing that.
Ma'am, your slides are visible. Please make them full screen.
Yes.
Yes, ma'am. Perfect.
Okay. So now Dr. Deepa tried everything, managed all the emotive protocol, but still the patient continues to bleed. So then the role of surgical management comes. So I will be talking on the stepwise uterine devascularization. So we know that prevention and prediction of PPH always pays, requires urgent and appropriate management. Resources of even well-equipped and staffed units may be stretched, so the staff should be familiar with an agreed protocol to be implemented quickly and smoothly. Mr. Rakesh, आपको करना होगा? Okay. Now coming to uterine devascularization. When is the need of devascularization? Conservative management has exhausted. Reproductive function needs to be preserved as life-saving procedure in emergency, or even as prophylactic measure when you know that this patient is going to bleed like Akrita and all. Yes, Mr. Next. Now, PPH following vaginal delivery or cesarean section after abdomen has been closed. All medical and minimal invasive approaches are preferred. Laparotomy and vessel ligation will be the last resort. But PPH during cesarean section, uterotonics and uterine massage tried first, but operative intervention for control of hemorrhage are performed sooner since abdomen is open. Next. Time factor is the most important factor. Like dramatic events like PPH, they require fast action, quick to decide and quick to do. Vessel ligation should be rather considered earlier in the management of PPH. No time should be wasted in taking decisions. Ligation of major vessels feeding the uterus is an effective life-saving procedure. Next. Now, justification for vascular occlusion. 90% of the blood supply to uterus during pregnancy comes from uterine arteries. Occlusion of uterine arteries reduces most of the uterine blood flow. Occlusion of ovarian vessels results in additional deprivation of uterine blood supply. In uncontrollable hemorrhage, the feeding arteries lose their ability to constrict. So ligation seems to be treatment. Vascular, okay. The first pelvic artery ligation was hypogastric artery ligation done by Queens et al. In 1898. Bilateral uterine artery ligation was done by Waters in 1952. And later, O'Leary demonstrated his vast experience on this. Stepwise uterine devascularization was done for PPH by Abrabo in 1994 from South Africa. The author reported 100% avoidance of hysterectomy by using stepwise devascularization. Next, please. Now, what are the steps in this? Step-by-step uterine blood supply obliteration for control of PPH unless cessation of bleeding occurs. Now, the first step 1, unilateral uterine vessel ligation. That is, in cases of extension of uterine incision or uterine artery laceration has occurred. Uterine vessel, step 2 is step 2, bilateral uterine vessel ligation in cases of uterine atony or abruptio placenta. Next, please. Next, the step 3, low bilateral uterine vessel ligation. That is in cases of lower uterine segment hemorrhage or placenta previa or accreta. Step 4, unilateral ovarian vessel ligation if a part of the uterus is covular. Step 5, bilateral ovarian vessel ligation in cases of covular uterus or the atony which is not being looked after, hemorrhage not stopping from step 1 to 3. Hypogastric artery ligation is not a part of stepwise devascularization, but by itself it is a life-saving procedure. Next, please. Next. The procedure of uterine vessel ligation. The uterus is grasped with the hand elevated anteriorly and to one side with 4 fingers posterior to broad ligament. This part is very important. The 4 fingers should be posterior to the broad ligament and thumb over the lower uterine segment. Uterine artery ligated at the level where it runs along the uterine border beside the upper part of lower uterine segment. A large Mayo needle with number 1 atraumatic chromic catgut suture is passed through the avascular area of broad ligament and brought forward through the myometrium and tied. Caesarean section, when you are doing, the suture is placed below the uterine incision, roughly 1 centimeter, under the reflected peritoneal flap. Next. So now here it is very important to take the needle through the myometrium. That is a very important part. So that ultimately your ligature should be taking this uterine artery along with the venous plexus with this. The taking through myometrium, why it is important? Because if your needle goes through the vessel, the AV fistula may occur later on. So you are putting the needle through the myometrium, medial to the uterine artery, and your finger behind is guiding this needle to come through the avascular area and the broad ligament, and then tied. Next. Next, please. Yeah. So low bilateral uterine vessel ligation this is reserved for cases who continue lower uterine segment hemorrhage at caesarean section, not controlled by initial upper ligation. Step 2. Bladder needs to be well mobilized low, 2 to 3 centimeters below the upper ligature. Another ligature is placed where cervicovaginal branch of the uterine artery turns upwards. This ligature will obliterate most of the branches of the uterine artery to lower uterine segment and upper part of the cervix. Next, please. So this is the upper ligature or the lateral part of the lower uterine segment. And this is the lower ligature, which includes the cervicovaginal and corpus branch. You may have to take an extra stitch for that because it is difficult to include this corpus branch of this uterine artery. Next, please. Just run it, please. Run the video. Mr. Rakesh.
Ma'am, it is photo only, image only.
No, it is a video. You have to make it full screen and then.
Yes, ma'am, it is in full screen, but it is showing as an image only. I've received.
Oh.
But that's why I
And
sent
you
to
will
you that
probably
I
need to
may.
share the folder of the video containing the video. If
I
only the
have sent the
presentation
folder
has been.
with the clips.
It is a full image only.
No.
Maybe you can check the
I'll
folder and it is there
and
separately.
then maybe I'll show later on from the clips. So okay, show the next slide, please. I'll show now. Ovarian vessel ligation is the uterus is there are 3 different ways how you can ligate the ovarian vessel. Very easy one is to put a stitch in the infundibulopelvic ligament, but that should not be the preferred method. Very easy, but not preferred. The mesovarian, with the help of right angle clamp through the avascular area, pass a free ligature and tie the ovarian artery, supply to the tube, and the ovary is maintained by this. And you can tie it along with the ovarian ligament. That makes a good knotting. Or third is ligate the ovarian artery at its anastomosis with the uterine artery in the medial mesosalpinx, including the myometrium. Here also you should take a bite through the myometrium, not through the vessel. definitely. Next, please. Next. Now, anyway, I'll try to show these clips separately. So here is either you tie the variant ligament here parallel to the round ligament in the mesosalpinx, or you tie where it's anastomosing with the uterine artery and take the round ligament along with this in this tie. Next, please. Next, yes. Now, stepwise devascularization technique is relatively easy, simple, conservative procedure. Every obstetrician can perform it. Time required to perform this procedure is shorter. Procedure not associated with more blood loss. Vessels are not divided, so recannulation will occur. Effectiveness in the study of Abd-Rabbo from Egypt, the step 1 to 3, 93%, it was effective. And 100% effective in placenta previa. And in uterine atony, it was effective up to the tune of 97%. O'Leary experience over 30 years on 265 cases, 97%, it was effective. Otherwise, there are many other studies where they have shown just simply bilateral uterine artery ligation is effective to the tune of 80 to 92%. It is effective, it is very simple and without much complications. Next, please. The complications of the procedure are minimal in experienced hands. Broad ligament hematoma has been reported just in 1 to 2%. In O'Leary series, out of 286 cases, only 2 had broad ligament hematoma, which were managed right then only. The AV fistula, like I said, if you do not go through the myometrium, your needle goes through the vessels, then the chances of AV fistula forming later is there. Ureter and bladder injury only if you are very, very careless. Otherwise, it should not occur. Because you are pushing the bladder down definitely for uterine artery ligation, and ureter is actually away where the uterine artery is, and you will be careful. It is quite visible easily. Difficult to perform in face of distorted pelvic anatomy and massive pelvic hemorrhage. Bleeding from vaginal lacerations and cervical tear will not stop by this procedure. No long-term adverse effects have been reported. Next, please. Next. The future reproductive outcomes following stepwise uterine devascularization. There have been good number of studies now where they have seen that the bilateral uterine ligation does not affect the return of menstruation, does not affect fertility, does not cause uterine necrosis. Clinical course of pregnancy are uneventful. Placental insufficiency also not noticed. In Abd-Rabbo, 103 cases also, all those women who wanted to get pregnant, most of them got pregnant. No effect on menstrual resumption, fertility, and pregnancy outcome was recorded. And the next, please. Now, internal ligation, artery ligation, it is a time-tested life-saving procedure. It decreases pulse pressure by 75 to 85%, reduces blood flow by half. Arterial system changes into venous flow. Easier than uterine artery ligation in face of massive hemorrhage and when distorted pelvic anatomy is there. Clear concepts of pelvic anatomy are must when you are doing internal iliac artery ligation. This requires surgical skill and experience. Next, please. Now, how we do it? Peritoneum is incised lateral to the ureter at bifurcation of common iliac artery, or you enter the retroperitoneal space between the tube and round ligament. It is very easy to enter this space in the partum period because all the loose tissue is very loose. You do not need instruments. Just give a nick on the peritoneum and by your finger,
blunt dissection, you can reach the whole of the lateral pelvic wall. The artery is exposed by a blunt dissection. Bifurcation of the common iliac artery is to be visualized first of all. Ureter, internal iliac vein, external iliac artery must be identified. This is very important. You must identify ureter. You must identify external iliac artery, because the artery which comes in front, that is external iliac artery. The internal iliac artery is posterior, little posterior. So you have to definitely see the bifurcation of both and then take the medial one. The sheath is cleared from the artery, which is again very easy in the partum period. A right angle clamp is inserted below the artery from lateral to medial. Bilateral ligation is done with number 1 silk suture, and femoral pulse must be identified when you ligate the internal iliac artery. You have to ask a person who will check for the femoral pulse. Definitely, it is must. Next, please. Now, again, it will not work. So, common iliac artery, the external iliac artery is on the lateral side, internal iliac artery on the medial side. You ligate it about 2 to 3 centimeters below the bifurcation so that you do not pierce the posterior division of the internal iliac artery. And you take the clamp from lateral to medial because the veins are lying posterior. That if you go from medial to lateral, your tip may injure the vein because the vein walls are very thin compared to the arterial walls. The bifurcation, when we see surgically, it does not look like this. The bifurcation, it will be little, they will be overlapping each other. So you have to make sure you are not ligating the external iliac artery. Next, please. Next. So other uterus sparing intervention in PPH, compression sutures are effective in 70 to 75% cases. The risk of uterine synechia is there in about 5 to 10% cases from the different studies. This B. Lynch in 97 described the uterine compression. Many variants are there in literature now. It's by itself a full lecture, so I will not be going into details of all that. No evidence that one method is better than the other because no comparable studies. In fact, there are no comparable studies on any of the methods, uterine artery ligation, step-by devascularization, or internal artery emergencies. Hence, there are no guidelines also because there are no controlled studies. So choice of procedure is guided by operator's experience. It's appropriate to offer second surgical procedure if first one fails. Suppose you have done internal artery ligation, not internal, you have done step-by devascularization, patient is still bleeding, you can go for compression suture. Or if you have done compression suture first, but the patient is still bleeding, you can go for the vessel ligations. But when you are doing this, not to delay peripartum hysterectomy in hemodynamically unstable patient. So we have 20 minutes with us for using the uterus sparing intervention procedures. 20 minutes for the medical therapy, 20 minutes for these uterine sparing interventions. If the patient is still bleeding, we have 20 minutes more for peripartum hysterectomy. So hence means you can try both these methods, but be conscious of that time when the patient is not in a stable condition. Next, please. Next. Now, surgeon experience is very, very important for these vessel ligations. A national survey in France was conducted from 286 obstetricians that showed that 30 to 60% reported that they have not mastered surgical uterus sparing procedures. These were the attending obstetricians. 70 to 80% of the residents had not mastered these techniques during their residency. 80%, 18% consultants also had not mastered. So that is the lack of perhaps training in this. The compression sutures and vessel ligation have shorter experience learning curve. 4 to 5 procedures are good enough to master your compression sutures or vessel ligation. Internal ligation requires more experience. 10 to 12 cases you have to do under supervision, then only you can do on your own. So dissemination of these least invasive and least morbid procedures is essential. So it should be all the teachers who are attending this forum today, please make sure that you teach your residents these essential, least invasive and least morbid and very effective procedures. Next, please. So the clinical algorithms, medical management, yes, definitely all what Dr. Deepa told us, must try. Balloon tamponade, if by simple medical method not working, then uterus sparing surgical procedures. You can do either of the two, or once in a while, both these procedures can be done. Embolization is only in well-equipped hospitals where the intervention radiology part is very well standardized. But once you have done vessel ligation, you cannot do embolization. So that you have to judge the patient, which patient is for embolization, which is for vessel ligation. And then peripartum hysterectomy, of course, is there, which has saved many, many women. Next, please. So to conclude, stepwise uterine devascularization is an effective, safe, and life-saving alternative to hysterectomy. Bilateral uterine artery ligation is ideal for uterine atony and abruptio placenta. Low bilateral uterine artery ligation is ideal for placenta previa and accreta. Bilateral internal ligation is ideal in severe PPH or where pelvic anatomy is distorted and vaginal lacerations. The pelvic vessel ligations expertise should be present in the armamentarium of every gynecologist to control hemorrhage then and there, rather than searching for other specialty experts. Primary objective of such a program should be to instill confidence in the technique in a non-stress environment. It is inadvisable to perform ligation of big vessels for first time in a desperate situation. So what we can do is, while doing hysterectomy for any indication, we can open the broad ligament and show the whole anatomy and make the junior colleague or the resident pass a right angle clamp from lateral to medial in the internal artery. And the uterine artery, in all cesarean sections, we can show to the residents and make them do also ligation. So these are actually not difficult. The only thing is we have to really train our junior colleagues for this. Yes, next, please. Thank you.
Requesting chairpersons, Professor Rashmi Madam and Dr. Renu Chakrabarti Madam. If Dr. Rimi is there, then Dr. Rimi also, please unmute and share a few words.
Mr. Rakesh, put me back to that.
Hello, thank you, ma'am. It was a wonderful lecture, studying step by step in a mathematical manner.
Mr. Rakesh, you will stop sharing now. Please, I want to come back to the meeting.
Yeah, ma'am. I have stopped sharing. You can share, ma'am.
It was really nice, ma'am. I mean, after your talk, I started remembering all the difficult times when these things were done. And you are right that we need to practice this. If we don't practice it in a comfortable situation, we cannot think what's to be done in a difficult situation. I wish your videos could have played. They were amazing. But due to what reason, I don't know.
I do not know. For this reason only, I sent to him so that if they do not work.
Ma'am, you have to send the main file also, the base.
I sent the whole folder.
Then why they have not been playing?
I don't know.
A big problem.
वीडियो दिखांदे थे तसा सारा वधिया क्लियर हो ਜਾਂਦਾ
Nee, abhi bhi I'll try. I'm not able to come to the meeting part. Mr. Rakesh, help me. It's YouTube. Why it is
Yes,
showing
ma'am.
YouTube?
No, ma'am. You can go to the share section. It is there in
Share.
yes, share.
Okay. No.
Share
In
screen.
Zoom, ma'am. In Zoom.
In
meeting.
Zoom.
Yes, not in YouTube, ma'am.
I do not know.
And
The
just
upper
like
bar
you were,
is not showing.
just like you were screen sharing. अभी तो screen share नहीं आ रहा मैम.
I can see all of you, but I'm not able to see the.
मैम ये जो है नीचे देखिए मैम पार्टिसिपेंट चैट एंड शेयर लिखा होगा. हाँ, क्लिक ऑन शेयर बटन.
Click on share.
Yeah, share button.
No,
Click
share
on
something else is coming. Something
no.
else. No.
Yes, your screen has started now. Go to your presentation, ma'am. Now go to your presentation.
Anyway,
you can
carry on.
open your presentation.
Rashmi has a lot of input she can give. And
So,
Dr. Amrit Pal also, I read one study. She has published one paper on good number of cases where the output from that.
Ma'am, in the button, the presentation is there, ma'am. No, in below, ma'am. In the button.
In the?
Your
bottom.
Outlook is there, your mail, thereafter your Google Chrome, thereafter your presentation. Yes, go to your presentation.
Done. Ma'am, you are very much in the meeting, ma'am. Don't worry.
Doesn't matter. But I would like Rashmi to say more.
Yes, ma'am. So one step which you have highlighted is to learn in a comfortable time so that you can do it when it is an emergency. And the second thing is that when to take a call of doing a hysterectomy. The 20 minutes is a very good thing that we should not persist in this, that we have to keep on doing. And ma'am, for the compression sutures, we need to have a bigger needle. Usually the needles which are available are not there. So sometimes we have to buy needles, arrange them. They really have to be 6-7 centimeter long so that we are able to go through the two walls.
Rashmi, are you doing these compression sutures?
Ma'am, yes.
And which one?
Yes, ma'am. Yes,
which one?
Ma'am,
The original B-Lynch or there are
yes,
so
B-Lynch
many?
also, but supposing B-Lynch doesn't stop it, then we can put separate ones in lower part, separate ones in upper part. Basically, the walls should be opposed and it should be flexed. That is the aim. And we're using catgut. You also mentioned catgut, but we are also using catgut because we don't want this to stay for too long. Otherwise, it will cause Asherman syndrome.
Where they are using Vicryl, that is not right. That gives more synechia formation because the uterus remains compressed for a longer time. Synechia may form. So now they are recommending monofilament to be used. But what I always feel scared in B-Lynch is the uterus is big. A big loop is going. And this uterus is going to retract very fast in the first 2 weeks.
Yes.
When that big loop is there, I am always scared that a loop of intestine or small intestine may come in that.
Yes, ma'am.
I have always had this phobia, where it is not written anywhere in the literature, but I have had this phobia.
Yes, ma'am. So smaller compression suture, box suture.
Yes. I think one square, one upper part and one square, one lower part should be good enough.
Yes, ma'am. That is right. And another thing is now one concept is there that the central suture in the vagina, lower part of cervix vagina, there is some ascending colpouterine artery, which is now a new concept I also read recently. So that also helps. It is not there posteriorly, it is there anteriorly. So where you are putting descending cervical laterally, one more suture in the center, in the anterior flap. Also supposed to help. But anyway, we have to pray to God to get us out of these situations because they're very tiring, very taxing on everyone. Thank you.
Ram, Ram.
Chalo, let's go to the
Yeah,
Ashwina,
session
more
three.
important panel discussion.
Ashwina,
Yeah.
that
I now
would be.
hand. Yeah. Sorry. Yes, Dr. Vineet.
Ma'am was talking about one central that will be actually medial, medial to the lower uterine segment, where ma'am said ki you have to occlude the descending branch.
Yes,
There is the cervix, so that will be just in the central part.
Yes,
As
so
ma'am
madam has explained those two in the lower part, just below the incision, the uterine, and if it doesn't stop, then a little lower than that, about I think 2 centimeter lower, ma'am, if I'm not correct. For that, you have to mobilize the bladder more, because then the lower you go, the lower the ureter is at risk. That is done.
This
This
is
is a very
especially in
new
cases
concept.
of adherent placenta.
Yes, ma'am. Yes, ma'am. Where the lower segment is troubling. So, in addition to those two, one in the midline anteriorly. That is where there is one third artery called a colpouterine artery, which is coming from, or colpouterine, which is coming from below. This is a very new concept. I have done it in one case only. I don't know whether the bleeding stopped because of that or the lateral sutures, but this is something in addition. Maybe
ma'am
it just.
has given us homework for
Yes.
the day, ma'am.
Yes, ma'am. But really, ma'am has been through with us with many difficult situations. In fact, when you told me to take this lecture, I said this talk is hers only, and we have learned from her, and that is always it has
You
been.
are waiting for these videos. Only like the purpose of keeping this talk was कि ma'am के videos.
हाँ, ये थोड़ी सी ना मैंने इसीलिए मिस्टर राकेश को भेजे थे that he will be able to. I may not be smart enough to play those, so I sent him these
Rakesh
videos.
can put in the group afterwards also, ma'am, if it is
Yes,
possible.
yes,
so that
I
we
will
can all
send.
watch those
I will
videos.
send to all of you.
Thank you so much, ma'am. Wonderful.
Thank you. Thank you.
Hello, panel. Now we have and now I hand over to the next coordinator for moderating coordinating the third session. Dr. Monica. Dr. Monica, please mute yourself, or you Dr. Monica, you're coordinating this session. My God. Am I audible?
You are audible.
Okay, I don't know. I think Dr. Monica is. So I'll just continue with this. Are we having the panel first, or are we having the session 3 first?
Session 3.
Okay, sir. Okay, sir. Good evening, sir. Now for the next very interesting topic in legal issues in obstetric hemorrhage, we have again 3 eminent chairpersons. Dr. Monica, are you taking on, Doctor? Dr. Yash Bala, ma'am, Dr. Manjeet Kaur Mohi, and Dr. Jagjit Singh. Dr. Yash Bala, ma'am, is the Director of Obs-Gyn at Cloud9 Panchkula, and she's working as professor and head of the department. No, yeah, she's working as a Director of Obs-Gyn, Cloud9 Panchkula, past President, Chandigarh Obs and Gynae Society, best graduate recipient of President's Medal at PGI MES Rohtak, Executive North Zone UFOXY, past Chairperson Women's Wing, postgraduate and 6 years post PG experience from PGI Chandigarh, and invited faculties in national and zonal conferences, publications in international and national journals, and areas of interest as medical legal issues, high-risk obs, and preventive gynae. The next chairperson in this session.
Yeah, she not be able to join. She just messaged she had an emergency, so she had to go.
No issues, ma'am. No issues. It's our job to actually read out the CV.
That's okay, but she'll not be able to join, ma'am. She just messaged. Yeah.
Okay, Dr. Manjeet won't be able to join. Okay. The next chairperson, Dr. Manjeet Kaur Mohi, is working as professor and head of department at Gyan Sagar Medical College, Ramnagar, Patiala. Senior consultant, Fortis Mohali, and I think areas of special interest are vaginal surgeries, oncology, high-risk obstetrics, medical education. She has many publications and chapters in various books and in papers in many national, international journals. And she's a subject expert for selection of faculty in UPSC and State Commission. The next chairperson for this session could be Dr. Jagjit Singh. He's a senior medical officer, honorary secretary, Faridkot Obs and Gynae Society, vice president of All India Federation of Government Doctors Association, chief advisor, Specialist Doctors Association, Punjab. He has been an AICOG faculty for the last 17 years, master trainer of GI sponsored RCH programs, administrative officer cum consultant for PCPNDT and MTP Act monitoring with Health Department in Punjab. I request any of the chairpersons to please introduce our most eminent legal consultant, very loving person, and somebody who's always there with the masses, Dr. MC Patel, sir. Any of the chairpersons there?
I don't see anybody.
Okay, Doctor, it's indeed a privilege. For the first time, I think I'm introducing sir in this forum. It's indeed a privilege to introduce Dr. MC Patel, sir. We all know that he is the most suitable candidate for the upcoming FOXI elections, to presidential elections in 2026. So he's a person with the masses, for the masses, and we would love to have him by the masses. By masses, I mean by all obstetricians and gynecologists from all sectors, A, B, and C type societies. His highlights are a FOXI uniform consent, medical legal training and support for members, Vice President FOXI 2018, Chairperson Ethics and Medical Legal Committee 2011 to 13, Organizing Secretary AICOG 2017, Honorary Secretary State Organization of Gynae Obstetricians of Gujarat 2022 to 2025, and Organizing Chairperson MMCon, VPCon, that is 2018. He's the Honorable Member of FOXI PNDT, Violence Against Doctors and Regulatory Cells. He has got a number of government and statutory roles, lots of community services, especially in the Northeast. He's working as Honorary Surgeon for Red Cross, iBank. His services in medical camps in Northeast under Dhanvantri, services in medical camps in Jammu and Kashmir, as well as the presidents of Lion Club in Ghat Lodhia, professional leadership as President AOGS, President IMA Ahmedabad, National President NMO, Organizing Chairperson Vivekananda NMO Con. So, ladies and gentlemen, I give to you Dr. MC Patel, sir, for once again letting us know about the medical legal aspects of hemorrhage.
Thank you, Dr. Nivedita, for kind word. Let me share my screen. Is it seen? Is it seen
Yes,
full
sir.
screen?
Yes, sir, full screen. Absolutely.
Fine. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice and wishing you all the happy Holi today. And thank you all the societies who have joined this webinar and all the president and secretary of respective societies who have joined this webinar. And Dr. Vineet Nagpal again, special thanks to you. I also thank you all because during my last election, you stood with me just like a rock, though I lost. But I believe in this. It was very nicely written by Shraddhe Atal Bihari Vajpayee, and I was lucky to work under him for some time. क्या हार में क्या जीत में किंचित नहीं भय भीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but new beginning, and journey to serve FOXI continued with renewed patience, and still my commitment is there. Wherever you are, I'll be there. Promise to reach the unreached. So I'll be seeking your blessings for the same post, President FOXI, election year 2026. Election would be from 1st August to 10 August, but before that, in month of April or in month of May rather, there will be call from Oxy to each and every society for nomination. So it is my humble appeal to nominate my candidature from your society and at the time of vote and support. Usually I start any of my talk with this question. Is it worth discussing? Yes. If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. You go any area as far as medical legal part is concerned, whether civil suit, criminal cases, CPA, Human Rights Commission, government level, MCI, NMC, wherever you go, as far as statistics related to litigations are concerned, we gynecologists are in driving seat. We take utmost care of any of our patient in our day-to-day practice, but we never know. It may happen, and once accident happens, it becomes a potential area as far as litigation is concerned. And our situation is like this. We have to save mother, we have to save baby, and at the same time, we have to save our own cap, and that is our obstetric practice. Let us say this is a real happen case in state of Gujarat only. It was unbooked patient, primary 34 weeks with PIH. It was the very first visit of that patient with this gynecologist. Of course, patient was seen by another gynecologist in another town. But in Gujarat, there is customary tradition that in primary, patient is delivered at maternal place. So she had been to her maternal place. And with this gynecologist, it was her very first visit. So he advised all necessary investigation on first visit and necessary treatment. But unlucky patient and that gynecologist too, very next day she developed abruptio and intrauterine fetal death. Cesarean section was advised. Relative opted option to go for second opinion. They went to surgeon in nearby town. Cesarean section was done. Again unlucky patient and that surgeon too. She developed atonic PPH, and in spite of all their efforts to control bleeding, ultimately hysterectomy was done and notice was served, case was filed. Imagine the situation, primary patient, IUFD and hysterectomy. So allegation to first gynecologist was not properly managed to prevent abruptio placentae. I was defending both of them, gynecologist and surgeon in this litigation. So my argument in court of law was that in this case, on very first visit, my gynecologist had investigated that patient thoroughly, as any prudent gynecologist would have, and he had advised all the necessary treatment. But unlucky that patient that she developed abruptio, he advised cesarean section immediately to go for, but patient opted option to go to another town for to another surgeon. So in this case, gynecologist was out of problem. As far as surgeon is concerned, allegation was not tried to prevent PPH and atonic PPH was not managed properly. Again, in this particular case, surgeon was operating and gynecologist was assisting in this particular case of cesarean section. So at the time of this PPH, they tried their level best to control bleeding with oxytocin, ergometrin, carbetocin, prostaglandin, everything they tried. They infused 2 units of PCV also. They tried to go for compressive suture and stepwise devascularization also. But in spite of all these efforts, bleeding was not getting controlled. So to save life of patient, there was only resort to go for obstetric hysterectomy, and they went with obstetric hysterectomy. So in court of law, my argument was that this surgeon and gynecologist both have tried their level best to control bleeding, but there was no option available, and to save life of patient, it was the only option. So we have not removed uterus, but we have sacrificed uterus to save life of patient, and luckily in this case, both were set free and we won the case, gynecologist and surgeon. So how you put your case before honorable court in this type of situation is very much important. Let us see one more case. It was happened and decided in Supreme Court. It was again case of lower segment cesarean section, atonic PPH after cesarean delivery, uterotonics given. In spite of applying sutures, bleeding PV was 3+, informed consent was taken. subtotal hysterectomy was performed. Blood and its components were transfused to correct hypovolemic shock. But in this case, argument on part of doctor was it was life-saving emergency and pursued standard medical books, that is Shaw's standard textbook of gynecology and Williams standard textbook of obstetrics. And in both the books, it is very specifically mentioned that post-mortem hemorrhage is well known. It is dreaded and leading cause of maternal morbidity and mortality worldwide, even in the best centers. And process of childbirth can take a lethal turn. Only a qualified obstetrician can understand uterine atony after childbirth as the most common cause, and it can lead to rapid and severe hemorrhage, shock, DIC, multiple organ failure, and finally death. And in fewer the study, the most common indication of emergency obstetric hysterectomy was uterine atony. It was in 25% of the cases, followed by morbidly adherent placenta in 21% of the cases, and uterine rupture in 17% of the cases. So with this, court was very clear and inference held by the court that it is a very important surgery to save life of patient. So this reflects the situation in most developing countries where atony accounts for majority of cases of emergency obstetric hysterectomy, but also shows a rising trend. So further inference held by the court was if all attempts at arresting bleeding have failed, subtotal or total hysterectomy is attempted as a last resort and life-saving measures. And decision to perform hysterectomy, although devastating for patient, should not be delayed in case of hemodynamic instability. So in this particular case was decided in favor of doctor and appeal was dismissed from patient. So with this type of cases, which are the areas for litigation where we end up into litigation? Which are the common allegation? Delayed in diagnosis, investigation, or treatment. So we should be very prompt to diagnose case of PPH and we should be very prompt to deal with accordingly. Rightly mentioned by Dhaliwal madam also, as far as surgical interference is concerned, if at all it is required, it should be immediate without wasting time. Misdiagnosis, investigation and treatment, wrong diagnosis, unnecessary investigation, no proper consent, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all patient is to be transferred to higher center, it is also taken into consideration whether it was undue delay in transfer, then it becomes a point for litigation. Complications, morbidity maternal and or fetal, mortality maternal and or fetal, overcharging. Nowadays, this has become one more allegation, tremendous expense against an unexpected result. And naturally, in this type of cases, expense could be anything because we have to involve another professional colleague, other consultants also. Ask for medical record and not provide. In this type of situation, many times patients and relatives are interested to have record. And if we do not produce record to them, then also it becomes a one more area for litigation. And failure of patient to keep up schedule follow-up. Whenever we advise patient to come for schedule follow-up and patient is not coming regularly for follow-up. But again, if we can prove it, then it becomes a good defense in our favor because if patient doesn't follow our instruction, it becomes contributory negligence on part of patient and it becomes good defense in our favor. So court and law expect from us to anticipate and to be prepared to deal with that very situation very promptly. So not anticipated PPH or not anticipated certain complication, and if we are not readily available to deal with the situation, then it becomes a area for litigation. And whenever we are facing this area, then usual question is asked, was it preventable? Was that PPH was preventable? And if at all it ended into hysterectomy, then was it preventable? It's a very important question. And sorry. So usually we cannot say no, and if it is yes, then one more question we'll have to face. What did you do to prevent it? So all our efforts to prevent PPH should also be taken into consideration, and we will have to show it in our record. If at all you couldn't prevent, then one more question, why you couldn't prevent it? And very important question, did you diagnose in time? And one more important question, did you manage way in which any prudent doctor would have managed in that very given situation? If we can answer all those questions, then we could be out of problem. Delayed in diagnosis, again, we will have to face all those questions. Recurrence, it is very common because mentioned by Dr. Goel madam also. Once bleeding is stopped, it is not, we have not to taken into consideration that it is stopped forever. So she may have a second bout also. And if at all it happens, one more allegation, no proper care taken to avoid reoccurrence. And again, all those questions we will have to face. And this is our observation during our medical legal practice. 80% of the medical legal cases against gynecologists are obstetric related cases. And out of those, 80% cases are related to cesarean section complication. And out of those, 80% complications are related to hemorrhage. So if one wants to be 80% free of litigation, then take care of bleeding and cross-match blood. Let us say this is real happen case in city of Ahmedabad only. It was case of lower segment cesarean section. Unlucky patient and that gynecologist too. During cesarean section, it was bilateral uterine artery tear. Patient was RH negative, blood was not ready, cross-match was not done. And in this particular case, during shifting patient to nearby municipal medical college, patient expired on the way and case was filed, notice was served, allegation was not anticipated complication, procedure and intensive care. As such, in this particular case, patient had been to this gynecologist 4 days prior. She was admitted, she was advised elective cesarean section with all preparations of blood because as she was RH negative. But patient absconded from the hospital after 4 days. She again came in the hospital in emergency middle of the night and doctor had no time to send even sample of cross matching in nearby blood bank and she had to straightway rush to cesarean section considering the condition of the patient and this happened. But in this particular case, inference held by the court was in PM examination, it was shown that it was intra-abdominal hemorrhage following negligent surgical procedure and no blood kept ready and medical records not to be believed because note of gynecologist and note of anesthesiologist was in contradiction. Because in note of gynecology, she had mentioned that vitals were within a normal limit. And at the same time, in note of anesthesiologist, it was written that vitals were compromised. So notes were contradictory. And in this condition, this record was not taken into consideration by court and compensation of rupees 2.35 lakhs was awarded in favor of patient's relative. So common reason for litigation, just I mentioned prior also, not cross-matching blood during high-risk pregnancy, particularly when you are dealing with a case of RH negative. So one more important carry-home message, would you advocate prior cross-matching in each and every patient? Because few of our friends have a habit to send sample in nearby blood bank on the admission only and keep 2 units ready in nearby blood bank. If at all it is required, then they will demand, and if not, but it shows their consent to take utmost care in given situation whenever it ended into PPH. Cross-matching specially for RH negative patient. When you are dealing with RH negative patient on admission only, there should be at least 2 units available in nearby blood bank after cross-matching. Consent for blood transfusion, it is very much required because in one of the cases, court has very specifically mentioned that surgery involves risk and blood transfusion involves additional risk. So consent for blood transfusion should be taken separately and proper record keeping, just I mentioned, it is very much important because obstetric hemorrhage are like 9/11 and it is very late sometime when we diagnose the thing and we cannot be smarter every time like this. So we should be very careful and it is very common. that after the ship is sunk, everybody knows how it could have been saved. So we should be very vigilant in this type of situation, because every case of PPH is potential threat as far as litigation is concerned, and treating serious patient could be suicide. And we are bombarded with so many questions when we face PPH and ultimately ended into hysterectomy or so. Where were you and why this happened? How you couldn't, how this happened? Why you couldn't prevent it? Who is responsible for that? So we are bombarded with so many questions. So what to do and how to prevent? So we have to observe only three things: foreseeability, anticipation, proper communication and consent, and documentation. As far as foreseeability is concerned, just I mentioned prior also, court and law expect from us to anticipate certain condition and complication, and we should be readily available to deal with situation. Say for example, if it is a case of central placenta previa, naturally one should anticipate that she may end up into PPH, she may require blood transfusion, she may require obstetric hysterectomy, and if we are readily available to deal with situation, it shows our concern to save life of patient. When one should be vigilant or anticipate PPH, particularly atonic PPH, if it is a case of multiple pregnancy, grand multipara, large baby over 4 kg of weight, anemia, polyhydramnios, prolonged labor, placenta previa, placental abruption, retained placenta, remnants of placental tissue, retained amniotic membrane, blood clots, mismatch third stage of labor, full bladder. So whenever we are seeing all these conditions, we should be alert, we should be vigilant, because this case may end up into PPH and we could be in trouble. One more area. Would you like to involve other colleague or would you like to treat alone? So whenever you are facing this type of situation of PPH, always involve your professional colleague, because it shows your consent to save life of patient and it shares responsibility also. So involve professional colleague, and preferably since beginning whenever you are dealing with high risk pregnancy cases, because balanced teamwork is always good for patient and it is also good for doctor also. But proper counseling is very much important. And one more area, whenever you are facing this type of situation, or whenever you are dealing with high risk pregnancy cases like abruptio or like placenta previa or so, in these particular cases, at the time of counseling, we should be very clear. Would you give guarantee in this situation? No, no rosy picture about result, no tall claim about result, because in our obstetric practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture in obstetric hemorrhage, and records are always at our rescue. So whatever we have done in good faith of patient, it should be well recorded. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. And it should be easily acceptable whenever offered in the court. Records in record, important bills are very much important part of your record. Purchase of oxygen cylinder, defibrillator, ventilator, emergency instrument like ambu bag, and all emergency drugs. And not only purchase of oxygen cylinder, but bill of refilling of oxygen cylinder is also important part of your record, because in this particular case, allegation on part of relatives was when patient suffered heart attack, oxygen cylinder were empty, and we were saved in this particular case only due to we could produce in court of law bill of refilling of oxygen cylinder just 1 day prior. So we should be very careful in this type of situation. And very rightly mentioned by Dr. Dhaliwal madam also, we should be very careful about all our instrument and equipment and our emergency kit. So check your equipments, instrument, medicine at regular interval and keep them up to date. Particularly, we should have separate box for PPH. And in past, Foxy had provided all this box with all emergency drugs, IV set, ampule cutter, everything was there in that very box. And once we open that very box, it should be available for to deal with any patient of PPH. And very important part, we should check that box at regular interval, not to have expiry date drugs in that very box. So it should be very clear. Transfer of patient, many times we have to transfer patient to higher center. So in this situation, it should be in time, at proper hospital, confirm availability of bed, ventilator, OT, blood, with proper and right person where you are referring the patient, escort patient in the same ambulance, handing over to the proper person, and we have to give all the transfer document to the patient, and we have to use pneumatic anti-shock garment. It shows your consent, it saves your time to dealing with the patient in case of hypovolemic shock. So this is all the transfer document we have to give to the patient. This is list, but we have not to worry for all this. It is available on Foxy website. Preserve all the transfer notes which you have submitted to the patient and patient relative. One copy should be with you. So on Foxy website, with title of Foxy Uniform Consent, there are 30 different consent. We three medical legal experts, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and I self, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. In that very consent, how to take consent and which kind of document should be given to patient at the time of transferring patient to higher center is there. You have to simply download those consent and you can use in your day-to-day life. So to conclude, there is always a way. So with carry home messages, antenatal and labor ward protocol we have to strictly follow. Adequate supervision and monitoring during labor, during surgery, even post-operative and post-labor. Communication, counseling and proper consent. Documentation and proper record keeping. Foreseeability and anticipation. In-time transfer. Multi-speciality approach. Medical audit of our own case where things went wrong so that this cannot happen again in future. Indemnity is must in era of CPA. One cannot practice without indemnity, and it is very important part as far as realization is concerned that medicine is a science of uncertainty and art of probability. And the problem with world is that intelligent people are full of doubts while stupid ones are full of confidence. So we have to decide where we stand and remain alert every time. Otherwise, be ready to face this type of situation. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many judgments in Supreme Court and in Honorable High Courts also in our favor in case of PPH also. But if we do not know, then it won't be helpful. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So to conclude, if you want to sleep like this, take tender care of your patient, comply with the provisions of law, involve your professional colleague, pray Almighty God before going to sleep, and keep my visiting card below your pillow because I am always there to help you, to assist you in any odd medical legal situation. So all the best. God bless you. Have a litigation-free medical practice. With regards, and again, with request to endorse my candidature for post of President Foxy election year 2026. Salute to all. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much. If there is no question, then we can switch.
Good evening, sir. Can
Yes,
I ask
welcome.
one question, sir?
Welcome, Dinesh.
Sir, is it necessary that in all cases of cesarean section or normal delivery should we explain the patient that there might be PPH and we have got for hysterectomy?
Yes, a probable complication we have to explain. And if you go with that uniform consent which is available on Foxy website, we have prepared consent for normal vaginal birth also and for cesarean section also. In both the consent we have mentioned. There are, of course, rare, but there is possibility. That way we have mentioned. Possibility of PPH. And in spite of all our efforts, if bleeding is not getting controlled, then possibility of hysterectomy should also be kept in mind. We have mentioned that also.
Okay. But if we keep on telling patients ki uterus may be removed, then I think they might be scared so much and they
in
may
your
not turn up
consent
next time.
paper, Dr. Dinesh, in your consent paper, if you have mentioned this, do you think that patient or relative are going to read all the papers of your consent paper? 2, 3 papers or whichever?
No, but sir,
Once
the
paper
thing is
signs
that
the document, once patient and patient party signs the document, it is presumed by law that whatever written above was accepted to the patient, and then after they have signed the document, it becomes a good defense in your favor.
Dr.
Yeah.
Rakesh, Dr. Manjeet Mohi is trying to log in since the start of the webinar. So she has called. Please let her in. She's trying since.
She might have logged with
Maybe she has logged in the YouTube. I have sent the faculty link also.
with delegate link. She would have she will be trying to log in.
I don't know,
So
Dr. Rakesh.
you can promote her from delegate to faculty link.
Sir, I have sent the faculty link also. Dr. Rakesh, please help her to join because she is like waiting since long and she's messaging me again and again. Please help her.
Okay, ma'am. Okay.
I have
So,
sent the
Dr. Vineet, with your permission, may I make a comment?
Sure, ma'am.
Yes, ma'am. So, Dr. Patel's talk was very interesting and very kind of, you have to thought-provoking. So, like you said, PPH will occur in women with high risk factors, but half of the patients of PPH will occur in women without any risk factor. So, it is probably a good idea to have cross-match blood, at least cross-matching done for every case because we don't know when PPH will occur.
Yes.
That is one, yes. So, yes, consent, written documents, of course, we all know. And the second thing you said was referral. When you are referring, have your referral notes, everything in order. So, what I have felt in PGI, sometimes when patients are referred, sometimes the doctors actually accompany them. They may be from nearby nursing home and all. And when the doctor accompanies the patient, the outcome is always good. I will not say always good, it is always better because one is we get a first hand notes. Okay, this is what happened, this is what I've done, and this is where we are. It saves a lot of time and it saves a lot of trying to read, trying to ask the history again and again. So, and even the patient feels that my doctor did not leave me alone, they have come. And we always welcome. We say, okay, now you have had enough. You sit down, have a cup of tea, give us the over, and we will take over from here. If we have that kind of a rapport, then things are going to become better because PPH can be anybody's nightmare. And here we have to just support and help each other. And Dr. Deepa's lecture was also very, very good. Dr. Deepa, I have been taking pictures of some of your slides because it's a very new thing which you have told us. Only thing I wanted to add at some point was that catheterize the patient. I was looking for that. So you had the picture of anti-shock garment also. So catheterization, bladder catheterization very early in management of PPH is a key step to monitor output as well as help in bimanual compression.
Rashmi madam, recording of this very webinar will be available. So at your leisure, you can go through again all these lectures and this panel also.
Yes,
One more thing, when I was in full-fledged obstetric practice, it was my habit to send sample in nearby blood bank and to keep 2 units of PCV always. Of course, in a very rare situation, we had to demand, but we were keeping all this ready. And it shows our concern to save life of patients.
Yes. And in cases of placenta percreta, we always get immunohematology done, auto antibodies tested because they need massive transfusion. So you can call that extended cross match also. You can call it a immunohematology report so that any odd antibody is picked up early and we can deal with that.
Sir, can I add one comment, ma'am, please, sir? The blood with problem with the blood, sir, a lot of time the blood bank charges them. Even they are keeping cross match blood. A lot of people, if not used, they are angry.
For cross
You
matching,
wasted my
etc.
money.
For the patient.
So that is the problem comes sometimes we face.
We have to counsel patient very properly, and charge of cross matching. Usually, if we can counsel well, patients are ready to go for. We are explaining them that if at all it is required, then only we are going to demand. Just now you have to spare only charge for cross matching.
Yeah, but they are charging the full money amount for the blood, no? That's the problem.
Absolutely.
No.
Cross matching is
Yeah.
also 1,200 rupees, sir.
Yes.
Yeah. I think government should do something that for any cross matching and keeping blood stored, it should be less amount if possible, so that it's within the reach of most of the people and they are not avoid it.
So, sir,
It
in
should be
our
acceptable
place, the
now.
charges are different. It's 600 for if we just keep it for cross match, and it's 1,500 if we actually issue it. So maybe different blood banks have different policies. Otherwise, mostly if we just cross match, the charges are lesser.
Okay.
Here
then
at
should we
Firozpur, we have to
panel?
provide the blood bank, the donor also. In emergency also. You have to, if no donor, then no blood. The problem is there.
That's the thing in government setups, but private.
That is an entirely.
Thank you all. Dealing with a bad PPH now, you're ready to donate yourself also. That is the situation.
So I think we can move on to the panel discussion now. And
Yes.
I hand over to Shatabdi.
Yes.
I
Thank
see
you, ma'am.
Shatabdi with a beautiful smile out there. That is wonderful.
Thank you,
Yeah,
ma'am.
she is always smiling.
Thank you so much, sir. We will move on to the panel discussion. We actually were enjoying the discussion that was going on after sir's lecture, but I think we have to move on to the panel now. We have a very interesting panel coming up. It's on case-based discussions in PPH. Moderator is Dr. Vineet ma'am, along with Dr. Nitasha Gupta, and we have Dr. Reeti Mehra ma'am and Dr. Alka Sehgal ma'am as the expert panelist. Now, Dr. Vineet is a senior consultant in Chandigarh, formerly assistant director in the Department of Health and Family Welfare, Punjab. She is the course coordinator for this program. Yes. We next have Dr. Nitasha Gupta. Dr. Nitasha is an IVF consultant and a cosmetic gynecologist, also joint secretary in IFS Haryana. Welcome, Dr. Nitasha. We have Dr. Reeti Mehra ma'am as an expert panelist. Ma'am is a professor in GMCH Chandigarh. She also is the recipient of the Rashtriya Gaurav Award and has a fellowship in endoscopy. Welcome, ma'am. Along with her, we have Dr. Alka Sehgal ma'am. Ma'am is an ex-professor and HOD of GMCH Chandigarh. And also she has over 100 national and international publications and chapters to her credit. Welcome, ma'am. We have a very interesting group of panelists with us. Our first panelist is Dr. Dinesh Pathak, sir. Can we have sir CV, please? Sir is the president of Firozpur Obs-Gynae Society. Very, very approachable. Whenever we have contacted him, he's always been there. He is a senior divisional medical officer. Welcome, Dinesh, sir. Next, we have with us Dr. Sangeeta Pava, ma'am. Ma'am is the HOD of Obs-Gynae at SGRD Amritsar, professor and head of department. She is also a member of Foxy Indian Menopause Society, ISAR, as well as IFS. Welcome, Sangeeta, ma'am. Thank you so much. Next, we have with us Dr. Professor Preeti Jindal, ma'am. Ma'am is the director at Touch Hospital. She's an advanced IVF, recurrent miscarriage and high-risk pregnancy, as well as cosmetic gynecology and laparoscopy specialist. Welcome, Preeti, ma'am. Next CV, please. Next, we have Dr. Bharti Goyal, ma'am. Ma'am has a master's in public health from John Hopkins University. Is a fellow of the Indian College of Obstetricians and Gynecologists, also a recipient of Global Grant Scholarship from the Rotary International. Welcome, ma'am. Next CV, please. Next, we have with her Dr. Japleen Kaur, ma'am. Ma'am is a consultant and laparoscopic surgeon as well as IVF specialist at Healing Hospital and Institute of Paramedical Sciences, Chandigarh. Welcome, ma'am.
Thank you.
Next, we have Dr. Anupam Goyal, ma'am, with us. Ma'am is has done her postgraduate and senior residency from PGIMR, Chandigarh. Is a fetal medicine trainee from AIIMS, Delhi. Also a life member of various organizations. Welcome, ma'am. Next CV, please. Next, we have with us Dr. Manisha Jain. Manisha is a fellow colleague from Nova IVF Fertility at Chandigarh. She has a fellowship in reproductive medicine and clinical endocrinology and has presented various papers in various regional, national, and international conferences. Welcome, Dr. Manisha. Next, please. Next, we have with us Dr. Meenakshi Rohila, ma'am. Ma'am is a professor in the Department of Obs-Gynae at PGIMER Chandigarh. She has over 22 years of teaching experience as well as is the secretary of the Obs-Gynae Society of Northern India. Welcome, ma'am. I think that's about it. Over to you, Vineet, ma'am. We also have Dr. Ruchi Ahuja, ma'am, with us. Ma'am is a PhD in breast diseases as well as an FICOG. So welcome, ma'am. Over to you, Dr. Nitasha and Vineet, ma'am. Looking forward to a good panel.
We have also Dr. Mangla Dogra, ma'am, with us in the panel. So she's traveling right now, but she may join in between. So I have my co-moderator, Dr. Natasha Gupta, with me. So Dr. Natasha, can you please share the presentation? So after the stage is all set by three beautiful, beautiful talks by our senior faculty, medical management and the FIGO guidelines were very much, covered by Deepa ma'am along with the other conservative management, and surgical part was very well taken by Dhaliwal ma'am. And we were relieved also and a bit, scared also with the Dr. MC Patel's talk, which is always, very supportive. The three things that are important are counseling, communication, documentation, and of course, the stage is all set now. So I think the panel will be more of just brushing up or revising what we have already covered. So coming on to the previous slides, Natasha, come to the first slides. So we have already said that the definition is now defined, and the threshold has now been decreased, because we have seen that with 500 or 1000 loss that we used to hear, we are still not able to decrease that maternal mortality rate to the tune that what we expected. So definitely something was not okay somewhere. So many associations, I'll be just going through that they came together for revising that what was actually needed. So the threshold was now decreased, and now blood loss of even 300 ml with warning signs, like we have already ma'am has said, that rule of 100 is there, pulse more than 100 or systolic BP less than 100, diastolic less than 60, and shock index, which is an important thing, that is more than 1. Any of signs with a blood loss of 300 or more is now defined as PPH, and blood loss of more than 500, even if she is hemodynamically stable and has no other concerning signs, still you have to act on it. Next, please. So the global MMR has been stated that is the leading cause of MMR in this century, also in this year. In this decade also, that we are still having postpartum hemorrhage as the leading cause of our maternal deaths, and it is to the tune of 401 in countries like Ethiopia, and 95% of all these maternal deaths occur in low or low middle income countries, as in 2020. And we know, all of us know, the 4 T's, that we have to identify the cause, but they may coexist also. So it is not that if a patient has atonic PPH, so trauma cannot be there, or retained tissue cannot be there, and this will not lead to thrombin. So a combination of all this is also important, but we have to really define what is the cause and identify the cause of bleeding. And for that, applying that 4T framework systematically ensures that every potential etiology is evaluated before and during intervention. Next, please. So global burden we have all seen. So that is the reason that the WHO, the international, the FIGO, the ICM, and UNFPA, UNICEF, JPIGO, they were all the technical collaborators so that we can now have a collaborative approach then how to save our mothers from this deadly complication. And coming on to the cases, we'll be just brushing the cases because all the learned faculty has told us everything. But now my first question is to Dr. Dinesh sir. Such scenario is that a 28-year-old woman delivers vaginally after prolonged labor. And within minutes only, she has now developed heavy vaginal bleeding and the uterus feels soft and boggy on palpation. So what is your diagnosis, sir?
So diagnosis is very much.
Hanji.
It's atonic PPH.
Is atonic PPH. Yes, sir. Next. So the risk factors for atonic PPH, sir, as sir has also defined, but these are some of the risk factors, though it is very true that I really, like Dr. Rashmi said that, whenever we are all prepared, when we know the high risk, then we are all prepared. But PPH can occur even in very, very low risk pregnancy where we're not expecting. So these are the cases which are actually, but there are definitely some risk factors, sir. Can you please elaborate those factors, sir?
Yeah, as it's evident that it's a large baby, the baby large macrosomic babies, because the uterus is much over-distended, so there is more chance of PPH. And even if there is history of previous PPH, then there is more chance that the PPH can occur. And in prolonged labor cases, if there is soldier dystocia, if there is pre-existing anemia, and anemia continues in the pregnancy, if there is multiple pregnancy, again the over-distension of uterus, if there is uterine fibroid, and also when we are doing some induction, then also after induction, there is more chance of PPH.
So, sir, talking about anemia, I think one thing is very important that in the FIGO, like in the guidelines FIGO update which has come, they have also said, I think Dr. Deepa will also agree with me and the other faculty also, that the antepartum, though PPH has to be dealt with, you have to take care in the antepartum period by correcting the anemia, which has now become a very, it has become as a separate note in the PPH guidelines, that antepartum treatment of anemia is an important part of the guideline now. Next, please. So, Dr. Sangeeta ma'am, Sangeeta Pawar ma'am.
Yes,
so what are the immediate steps in managing the uterine atonia?
Though profuse bleeding and relaxed uterus it indicates that it is atonic hemorrhage. However, bleeding to the retained bits should also be excluded. As soon as placenta is delivered, it should be inspected for missing cotyledons. And the first step on the management is good IV access, infused IV normal saline, send blood sample for blood test and cross matching, and uterotonics. Definitely, it is the first line of management for atonic PPH. Active management of third stage oxytocin infusion we are giving, but we are giving intramuscular injection of the 10 units during cesarean section IV, and during labor, during normal delivery, we are giving it as intramuscular. If bleeding is not controlled, then we can use other uterotonics also, and uterine massage should be done as soon as possible. Mesoprost, carboprost, yes, these are the second line choices. Ergometrin is to be avoided in the hypertensive patients. And when you are going the carboprost, take the history of bronchial asthma, and mesoprost can be given orally, sublingually, or per rectal, and definitely tranexamic acid within 3 hours, because after 3 hours it is not of much effect. So this is the first line of treatment. Then mesoprost.
Just a word about, like ma'am has already covered, I think we can, this thing. Can you come to the previous slide, Natasha? Natasha, the previous slides, the previous. One more. So this is very important. So this is very important that the postpartum monitoring has to be done. And from birth onwards, we have to check the signs for PPH, and it should be recorded every 4 times in first hour after birth to help. Early diagnosis is a must. So to help diagnose PPH quickly, and assessment has to be done. Next, please. Next, we have already discussed this. So this is very important. Dr. Bharti is there. Dr. Jablin, can you just discuss about the postpartum monitoring form which should be filled before? That, like Dr. Deepa also discussed, but just a word from you, Dr. Jablin.
Yes, ma'am. Like we talked about the risk factors. So first of all, we need to know the parity, the baseline heart rate, the pulse rate, any significant medical history like asthma, hypertension, we have to know, especially as risk factors also. And if we have to give the uterotonics, we must know which ones we can give and which we cannot. So then, of course, about the labor itself, whether it is prolonged, then if it's twin
In our case,
gestations
it
or
is a
it is a
prolonged
single
labor. So in our case, it is a prolonged labor.
Yeah,
That
one
is
risk
final
factor is prolonged labor. Yeah.
So definitely, this is one of the risk factors, and it is already mentioned in the monitoring form. So she's already
Yeah, so actually,
case of
basically all forms and checklists help us to remember. We may not remember at that time when things are panicking. So that's why these forms are important. So then you don't miss out anything. So
Yeah.
again, we look at the risk factors, the labor time. We must, even if it's an atonic, the first diagnosis is atony. Like Dr. Sangeeta also said, we must confirm that there is no placental bits and there's no laceration. So all those other things also have to be kept in mind.
Yes.
So that's how these forms will help you.
So
And of course, the
documentation, yeah,
baseline
yes,
HB
Dr.
level.
Patel was talking about the documentation, and when you have a format like this in front of you, you will not be able to,
Will not miss
out the
anything. Yeah.
things. Yes. So pulse, BP, diastolic, and जैसे मैम ने बताया, Dr. Deepa told about the shock index. Because many of the time we don't know that patient is going in shock, and immediately just we found that cold and clappy, and patient is like,
100, yes. Very good.
yeah. So now the threshold is really decreased. Otherwise, we used to 80 आ रहा है, अभी 90 आ रहा है. So the things have really come down to that. Even 100/60 is now taken as,
Yes.
and respiratory rate कि मुझे सांस नहीं आ रहा. Like your patient is also telling the
Yeah. Subjective things also.
You should listen to the patient, what she's trying. There is air hunger. She is like, मुझे सांस नहीं आ रहा है, मुझे घबराहट हो रही है, मुझे कुछ हो रहा है. So you have to listen to the patient because she is giving all the symptoms and you are seeing all the signs. And of
Right.
course, very important is urinary output, as Dr.
Yeah,
Rashmi pointed.
catheterization.
It's very important that you know when she is going in shock. So catheterization of the bladder is a must, and input of the input output chart is very important. And this medication, Japlin, you can this because this documentation is very important. Once you're referring the case to another place, what have you given? Trenexa has been given or not? Maybe they'll not repeat.
Yeah.
Can you elaborate on that?
Yes, ma'am. Like ma'am said, starting from I think how many IV fluids we have given, what kind of IV fluids we have given, to all the uterotonics, whether it was oxytocin, whether it was carbetocin, whether it was misoprostol, or whether Trenexa, whatever has been given has to be mentioned. And I think one important thing
The
is
time.
Yes.
Time of
The
giving
time.
that drug is very important.
Sure, because the team that receives the patient has to understand which things can be repeated still and which have already been exhausted. So they should not waste time on those again.
Dr. Vineet?
Next, please, Natasha.
Dr. Vineet, I wanted to make a comment if you allow.
Sure, ma'am, sure.
Dr. Meenakshi this side. I just wanted to add here that the catheterization is not just important for the documentation of urine output. It is the cause of atony.
Bladder. Yes, ma'am, it is cause for atony, so that is very important.
Yes, so we have when a patient has delivered and I am conducting the delivery, the first thing most important is the person who is conducting the delivery, who has conducted the delivery, is to catheterize the patient.
Yes.
The rest of the thing will be done by the person who or she is ordering to. Okay, so that's and I am really surprised that in a emotive also this has not been added. So it's a real very important thing. And I remember this from my residency time that we were always told that first catheterize the patient. And when a patient who has recently delivered, most of the time her bladder is full.
Yes,
most of
ma'am.
the
We
time.
have seen many
And
of the
that may
times
be
that
the cause
atonic
for
PPH
atony.
is just controlled by catheterizing the bladder and just a little massage.
Because the
So,
uterine
So
massage actually reaches the uterus once the bladder has
and
got.
exactly,
I
it
used to
won't
tell
reach if
my
the
staff
bladder is full.
nurses,
Otherwise, till then it's a waste. Yeah.
we
Yes,
used to tell our staff
yes,
nurses ki if you
yes,
have called the,
yes, yes,
if you have called the resident and you have not catheterized the bladder, so you
yes.
are in trouble.
So it's a
You are
blunder you have
in,
done.
yeah,
So I
that
think
is
it
a
should have
very
been in the
important thing.
emotive also. I don't know why
Yes,
it has been missed. Yes.
yeah.
Okay, carry on,
Ma'am,
please.
next question to you only, ma'am. The
Okay.
initial response bundle, the motive bundle has already been covered by ma'am. So now this patient, our patient who has delivered. So when is the time to escalate to the mechanical interventions like balloon tamponade and other? Next slide, Natasha. Meenakshi, ma'am.
Yeah, actually, as we have already discussed, it's a stepwise management of a PPH. We have already discussed, I mean, it's a first response for the PPH where we are managing. But if you think that we are not able to manage by all the things that have been already done, like medical, and we have given Nutrotonic, we have given tranexamic acid, we have catheterized the patient, we have given crystalloid also, we have put in double IV line, everything we have done, but still we are not able to see the effect, then it's the time to put a tamponade also. So it depends what kind of tamponade you have. So it's the time that you should, I mean,
And the
you
20
do not
minutes
have
will
much
work.
time to think. Yes, so it should be in a part of your armamentarium that if you are not able to manage PPS, then you have to proceed to this. And it's not a big job. You can do in fraction of, minute only, and you just put it in if you have. And you should be there always with all the obstetrician now,
Yes, ma'am. Next
whatever
one.
kind of tamponade we have.
The Chhattisgarh balloon is also a very nice alternative to Bakri if we can't afford it. If we can't
Whichever
afford.
you have and
Yeah.
whichever you can make the earliest
Places
possible.
which can't,
It's
yeah,
depending
afford.
upon your center and whatever, but it should be in your list now.
Dr. Ruchi, can you take up the next question, please? Dr. Ruchi is there?
Vineet,
Hanji ma'am, Dr. Kala ma'am. Hanji ma'am.
are you listening to me?
Yes, ma'am. Yes,
May
ma'am.
I say one thing in one line
Yes,
for
ma'am.
PPH?
Yes, ma'am.
That if you are vigilant for the first 1 hour
Yes.
after delivery, you will never get into trouble.
Yes, ma'am.
Because that first hour is very, very
Golden hour is
important.
very important. Yes.
If you lose blood slowly and nobody keeps a check on that, the patient, I have seen patients going into DIC. By the time the consultant comes, the patient is already in DIC because the blood loss was very gradual and nobody attached any importance to that.
Yes.
So that
True.
1 hour is very important. And as I think you may be knowing that we people in PGI or anywhere else, we used to start oxytocin drip. After delivery, you start the oxytocin drip, 20 units in 500 cc. Slowly give it and it controls everything.
Yes, ma'am.
This is a prevention, so you don't get into trouble. I have never got into trouble with BPH.
Thank you. Lucky, ma'am.
I think I consider myself to be lucky. Though I had a case against me, and that was for not giving anti-RH.
Okay.
Which I had given, and it was mentioned in the sister's record also. And the Professor Kala informed and advised RH antibody to be given fast. And 1.5 hours later, she got the RH, anti-RH. So that's it. So if you are careful, I think, but then you have to be not married like Dr. Kala. And you are all the time bothered about the patient.
Thank you, ma'am. Yes.
And I won
Yes.
that case. Ultimately, I won that case. Because we had recorded that patient got the RH, anti-RH negative antibodies. Thank you.
Thank you, ma'am.
I was listening to everything, and then finally I said
Ma'am,
that,
any of
that 1
the
hour, if
panelists
you are very
who is
careful.
there?
Pardon? If you are careful for the first hour, whenever I got patients of DIC, they were neglected patients after the delivery for 1 hour. And then we had to pay through our nose. Well, of course, one patient we saved by giving 28 units of fresh blood cut down on 4 limbs and 4 of us pushing the blood throughout night. But it is PGI then. It was 28 units of blood.
Ma'am, coming to that question only, Natasha, can you please put the slide for massive blood transfusion? Any of the panelists can take that. Dr. Preeti, Dr. Ruchi, Dr. Anupam.
The patient is losing also.
Massive blood transfusion.
And these are the slides for the surgical management in case now nothing is working. So what kind of surgical management each surgeon is actually will go through. So that's what was the...
Because ma'am was talking of massive blood transfusion. So just I wanted to highlight that key in what ratio it should
be. You have to be very careful for everything. That's what I said. That your monitoring should be very good. And then you never get into trouble.
Dr. Meenakshi Rohila, ma'am?
Dr. Vinny,
Yes,
can
yes.
I add something here?
Sure, ma'am. Sure, ma'am.
Sure. I think two things I would like to say. One is that the patient should be kept at optimal temperatures. This is very important in the case if the patient goes into shock.
Because she has to be properly covered.
She has to have better temperature. Okay? And as far as the catheterization is concerned, it is not that it is not mentioned in the guidelines, but they have not given that much importance to it. It does say, like I mentioned also, that patient should be catheterized if you feel the bladder is full.
Sure,
but the first step they also say is start massage.
Yes.
Because that is one of the most.
M is massage.
Yeah.
Ma'am, any of the panelists can take, because I cannot see who is there. Dr. Sangeeta, ma'am, can you please take
What is the question?
the massive blood transfusion? In what ratio the blood should be given?
Definitely nowadays we are going for the 1:1:1 ratio. PRBCs, FFPs there and platelets there. When we are going for the massive blood transfusion, then 1:1 ratio has to be kept. Otherwise, patient can go in DIC, and fibrinogen level should be more than 200. Should be maintained, and we should take the opinion of the hematologist also side by, so that what products has to be used instead, that should be checked also.
Dr. Japleen, are you there? Dr. Ruchi?
Dr. Vinny, may I add?
Bharti, yes, welcome back. You had an emergency to attend, so I'm so
Sorry,
glad.
sorry, yeah.
Thank you.
So,
Natasha, can you come on the surgical interventions now? Ma'am can give a quick this thing. Yeah. Dr. Bharti, when the medical management has failed and even the balloon tamponade has failed, now we come to the conservative surgery. Just a word about it, because ma'am has already covered, Dhaliwal ma'am, but how to go about this patient who has delivered, who has atonic PPH and is 28 years old, and she has delivered vaginally, ma'am.
So if she is delivered vaginally and the balloon tamponade has not worked, then the next step would be, and the basic, oxytocin massage and balloon tamponade has not worked, then everything has been done.
Yeah,
Then,
everything has been done.
Then we come to the compression sutures and bilateral uterine artery ligation. And that has to be stepwise devascularization so as to control the PPH. In this, when we are operating,
Madam has, Dr. Dhaliwal has covered the stepwise devasculation. So I
Yeah.
want you to please tell a word about the compression sutures, ma'am.
So, in a patient who has delivered vaginally, the Hayman suture work, or as Dr. Dhaliwal also mentioned that in those cases, the long suture, the long loop of the chromic catgut that might entangle a loop of intestine. I agree with her, but yes, I have applied Heyman suture in such cases, and otherwise the other option is the Chow suture, which is a rectangular suture in the upper segment and in the lower segment, along with the stepwise devascularization protocol that can be followed. So
Next
first of all
slide.
is compression. So for compression, it is Heyman suture, or if we are scared of the loop, the long loop of the chromic catgut, that
So we are applying B-lane suture.
Ma'am, your voice is broken.
We are applying B-lane suture. The chromic catgut is passed. We have never seen any loop of the gut is coming. Definitely, this is the worry. But I have never seen that any complication has arisen after B-lane suture. But definitely, Heyman multiple vertical sutures can also be applied as in Heyman stitch. And multiple vertical and transverse sutures can also be applied because the main mechanism is we have to collapse the cavity. Opposition of anterior and posterior walls, whatever is the method used, we have to contract and we have to see whether it is effectively reducing the bleeding or not. So B-length is very good suture. Otherwise, Heyman can also be applied. Chi-square can also be applied. If compression sutures are not effective, then definitely uterine artery ligation, bilateral uterine artery ligation can be used, and these arteries reduce the pulse pressure. And since there is lot of collateral supply, it is not undergoing avascular necrosis. This should be kept in the mind.
Very true, ma'am.
And care should be avoided to injure the ureter, as madam has mentioned rightly. We should see the ureter during uterine artery ligation.
Dr. Dinesh, when will you take the, Dr. Meenakshi, when will you take the decision for hysterectomy for her?
Even after 20 minutes of after doing the compression sutures, if the patient is still bleeding, continue bleeding, and it is not well contracted, then we should immediately decide, and the patient is collapsing, then we should go for peripartum hysterectomy.
And in hemodynamically unstable patient, I think
yes,
the decision for peripartum hysterectomy should be taken as a life-threatening, procedure, because then you cannot wait for that 20 minutes for that compression sutures or stepwise devascularization to give it a try. If the patient is hemodynamically unstable, and then the decision. Dr. Meenakshi, your take on this, ma'am?
Yes, I fully agree that if I done all medical management, I have put in this tamponade also, but she's not maintained, and you have now you have taken a decision to open the abdomen after normal delivery. So I won't wait much. I'll put a bilateral uterine artery if I see that I can see them and put in. I don't waste time in putting any compression suture. I'll take a decision that if she's uterus is absolutely atonic, and I have ruled out all traumatic cause, then I will go ahead with the hysterectomy because I don't have much time. I have already done so many things, and I have already gone through, half an hour probably by doing all this. So that all depends actually how the patient is behaving with you and how, how our vitals are. That is all depending upon the patient. How she's behaving now.
Yes, ma'am. Yes, ma'am.
Actually, it is the person who is managing is the right person to decide this. That these are the steps of PPA. That these things are all done simultaneously. Even if we are doing the medical management and putting tamponade, we are doing we are making the patient for we are making the patient ready for the surgical management also. We are sending blood. We are doing many things ready. So it should be a very fast decision, not wasting time on this. So it all depends on the
carry home message that this time is very important. So life saving is more important than uterus saving. So definitely the timely decision for hysterectomy has to be done, and it is most of the time it is peripartum hysterectomy that is the partial hysterectomy.
I think Lakhbir madam want to say something.
Dr. Vineet, can I add something here?
Sure, ma'am, please.
Which I have learnt very recently. Actually, we had a workshop on this manifestations that when you are applying these compression sutures, it is not the sutures which are going to stop the bleeding. At that time, not only that you first apply the suture, you have to roll the whole uterus like you roll the towel and then tighten the suture. That is the actual way how the bleeding is going to stop. And this was taught to in the workshop by Dr. Kavita Bhatti, who has attended a workshop at Delhi with the international faculty, and this was demonstrated there. And this point really makes a difference, because if you're rolling the uterus, it's so flabby, it will roll. And then you tighten the suture. Then it is going to be very effective in controlling the PPH.
I
Vinita?
agree. That will also
Vineet?
decrease the amount of loop, the size of the loop that is
Yes,
being
yes.
used to
Size of the
compress
loop. So
the uterus
as small as possible. The uterus has to be compressed as small as possible.
possible. Yes.
And then the compression.
And
And
another
then
thing I would
and then the
prefer.
suture also will not cut through.
Yes.
Sometimes there is also a problem with the cutting through. So I think this is a very good point when you are applying suture. I think
Yes.
Vineet?
Dr. Mohi
Hello?
ma'am, ma'am,
Yes,
Hanji ma'am,
yes.
please, ma'am, your take on this,
I just want to add, just recently I have also attended a workshop at Gurugram by this international faculty. They have taught one thing very important, is that we should do aortic compression whenever we are performing any of the procedures. If she is delivered vaginally, then we should do external aortic compression. If like patient is already open, then we should do the internal aortic compression. And this internal aortic compression can be continued till 90 minutes safely. And they have taught us the technique how to do it, that the femoral pulsation must stop. Only then we can say that the aortic compression is effective. And they have again taught us about the colpouterine vessels. Repeatedly, they were saying that despite of like we are tying uterine vessels, ovarian vessels, and internal lag, they say first you tie the colpouterine vessels. Like Rashmi said, 3 vessels are to be tied, 2
Yes, ma'am.
lateral and 1 in the middle, and then the bleeding will be controlled. And definitely whenever we are doing any of the compression sutures like B-Lynch or Heyman, uterus has to be rolled. First you have to tie the B-Lynch suture, then you have to close the uterine cavity. Do not close the uterine cavity prior to the tying the B-Lynch sutures. Then they taught us one thing, reverse B-Lynch suture in the cases of placenta previa, where the lower segment is bleeding. Like we are applying B-Lynch suture in the upper segment, similarly we are going to apply the B-Lynch suture in the lower segment. So basically the aim is to compress the lower uterine segment, despite like usually we used to do the bed suturing. We used to apply the bed sutures in the placenta previa. They said don't do like this. You simply compress the bed of the placenta by applying a compression sutures as you are applying in the B-Lynch sutures. Hello?
Thank you, ma'am. Thank you. Rashmi, yes, ma'am. Ma'am, point well taken. That
Dhaliwal
aortic
madam want to say something, ma'am. Dhaliwal ma'am
Dhaliwal
want to
ma'am,
say something.
I just wanted to say, even if you are planning to do peripartum hysterectomy, bilateral uterine artery ligation makes your job very easy. Just do that if it has not been done earlier. Number 2 point I wanted to say, never use Vicryl for any of the sutures, be it vessel ligation, any, or even for uterine compression. Vicryl, if you tighten the suture, it acts like a knife. It can cut through the tissue, it can cut through the vessels. So use the and always use thicker suture, never less than number 1, never less than number 1.
Thank you, ma'am. Next, please. I think we have saved the patient. And now I move to the, now I request my co-moderator, Dr. Natasha, to please take on the second. Any take, Celine ma'am? Yes, ma'am. Dr. Celine ma'am?
Yeah. I just wanted to say that only person who is well trained should be try to ligate the internal iliac, because I had one patient where somebody ligated the external iliac and the patient was still bleeding and she was brought to us, and in that case we removed the suture from the external iliac, but the patient had to have partial amputation of one leg because there was necrosis. So only person who is well trained should try to ligate the internal iliac. Otherwise, hysterectomy may be safer if one person is not properly trained for internal iliac ligation.
Yes, thank you, ma'am. Point well taken, I think, by our audience also. And here comes the part of training. So training the residents, training the junior consultants to do this in normal cases like Ma'am Dhaliwal. Ma'am Dhaliwal, can you please ma'am also
Yes.
ma'am also said ki it's better to try in a non-emergency conditions because these procedures are only to be done in emergency only, and they have to be tried in normal cesarean section, the uterine artery ligation, like ma'am said, so that you are able to do it when actually the time comes. So
Actually,
nobody knows
uterine
when
artery
the time will
ligation
come.
is
So,
uterine artery ligation is not a problem for all obstetricians. Those who are doing cesarean section, just when you are giving incision, just see laterally there is uterine artery. But for internal iliac ligation artery, definitely you need training yourself and you must train your juniors. Just first show them anatomy only 2-3 cases.
and
That
that's
this
what
is it. This
Dr.
is it.
Sareen ma'am said, ki identifying the internal iliac is very important.
Very good.
So,
The vessel which comes in front is not internal iliac. That's what you have to remember. The vessel which comes in front is external iliac artery. So you just have to, with your finger, you have to put that little on lateral, and there will be the internal iliac artery.
have been
Because
better to
the
go for
bifurcation is not like this. It is like
Yes.
this.
Okay,
It is
yes.
like this. So if it is like this, it's very easy to see, but it is like this. So you have to put the external iliac away, then you will see the internal iliac artery.
So the case that Dr. Sareen ma'am is saying, so it would have been better to do rather a peripartum hysterectomy rather than
And
by
in
mistake
case you
ligating
somebody
the
has tried it, always look for the femoral pulse.
femoral
Somebody must be, so even if you are very sure internal ligation done, it is a step definitely to palpate the femoral pulse to be seen. Definitely. It's one of the essential step. So that person must have been very, very careless.
Natasha, please
Sad.
take over the hair.
Vineet,
Yes, ma'am.
Vineet, can I add something more?
Sure, ma'am. Sure, ma'am. ਹਾਂਜੀ.
Actually, I am not using, but I have learned that the suction cannula like Penicor or SR cannula, they are very effective. Whenever a patient is having atonic PPH, I think PJ people, they are using this Penicor cannula for suction. As soon as the patient delivers, if they are suspecting atonic PPH, they just insert the Penicor cannula and then they attach it with a suction and the bleeding is controlled.
Yes,
One
ma'am. We have
thing.
added a line about it in the last of the panel. Yes, ma'am. We have
No,
added.
actually it is being taught in every workshop everywhere. PJ people, because I don't have a personal experience, I will
And
definitely
Dr.
try.
Rashmi, are you there? Dr. Rashmi,
Rashmi must be able to tell about it. And
Rashmi, ma'am,
second,
ma'am.
and one thing more which I have learned, like suppose there is a traumatic PPH. Suppose a patient with previous cesarean section has delivered and we are suspecting rupture uterus or some another problem, and we are just gaining a time before opening a case. Number one is the aortic compression. Second is the ligation of the uterine arteries by vaginal route. This they have showed by putting a laparoscope also. You just pull the cervix by holding with the two sponge holders on one extreme lateral end and just down as we explore the cervical tear, and a special clamp which is right angle like Paley's clamp, or I think I even we can apply the Leahy with then some rubber over it. then you simply apply that clamp just to gain the time till we are opening up the patient, just to control the bleeding. With this, they have got many papers and claiming that the bleeding is controlled.
Thank you, ma'am. Thank you. Natasha.
In case, she's a 32-year-old woman and she undergoes a instrumental delivery. Although the uterus is well contracted, but she keeps on with this brisk vaginal bleeding. And when we examine her, we find a bucket handle tear, suspicious of a deep cervical tear. So my next question is to Dr. Japleen. What are the high risk factors for the genital trauma per se? Dr. Japleen?
Natasha.
Yeah, and can we have Dr. Bharti?
Yeah,
Natasha,
the high risk.
she had to leave. She has sent a message. She had to leave for some emergency.
No problem. Dr. Bharti, can you take it up? What are the risk factors for genital trauma?
Yeah, instrumental delivery definitely is one risk factor, but so the basics of the basic prerequisites have definitely to be checked before applying any instrument. So that has to be taken care of. Then additionally, if yes, we've seen bucket handle tears with very forceful contractions of the uterus, and precipitate labor is one reason that can cause a bucket handle tear. Vaginal lacerations due to instrumental delivery. Mostly, I mean, even in cases of, when there is CPD and when
Lad
more,
size big.
yeah, the head size is too big. That can also cause vaginal lacerations, but most of the cases are because of instruments rather than just the bigger head size.
So, ma'am, how would we treat this patient of cervical tear?
Bucket handle tear, yes, again, it has to be visualization of the cervix. Am I audible?
Yes, yes, ma'am.
Yeah. So this has to be stitched in the operation theater, definitely. So the patient has to be shifted to the OT. Packing has to be done immediately so that we can we can control the bleeding for the moment. Then under good visualization, complete cervical exploration, and then
I would request others to please mute yourself because there is some disturbance coming. So, doctor, we are not able to hear Dr. Bharti. So, I would request all others to please mute till she is speaking. Thank you.
So once I've detected this cervical trauma, then first step would be tranexamic acid, 1 gram stat, packing, immediately shifting to OT, and then under good relaxation, exploring it and repairing it in OT with adequate resuscitation going on simultaneously.
When do we need to take her for laparotomy? When do we decide that we have to open the patient?
So if it is extending upwards, any injury that has extended upwards into the lower uterine segment, that will have to be dealt with by laparotomy. So if I see that the level of the tear is manageable from below, it is still below below the fornices, it is up to the fornices only, then I can deal with it vaginally. Otherwise, I'll have to open up the patient.
Okay, I think the other panelists will agree. Also, anything anybody wants to add in this?
Yeah, if there any supraelevator or hematoma, then that should be explored abdominally by laparotomy, because you are not able to do it per vaginally. And if it's small hematoma, small bucket, you can make it clear cut, the outline can be seen. Then small tears can be managed in the labor room also if the adequate exposure and good lights is available.
Sir, in case we don't want to open the patient and we are very clear, do you think in situations in which we have suspicion that the patient is bleeding or she is having hemoperitoneum, the radiologically or ultrasound bedside will be
Yes, ultrasound should be done. Yes.
Yeah,
When
there
there
is
is
one
no
thing,
external
FASO, we
bleeding.
call it FASO, the bedside ultrasound. You can do it bedside ultrasound and you can find out if there is any correction inside the abdominal cavity or not. So that might help.
Yes.
When there is no external bleeding, but the patient is in a hypovolemic shock,
Yeah.
then emergency ultrasound should be performed to look for the broad ligament or retroperitoneal hematoma, and immediate laparotomy should be done.
Very true. Right.
Agreed. True.
Another tip can I give?
Yes, ma'am.
Yeah. Whenever you are suspecting a cervical tear and there is a difficulty in exploring it, one thing is give the aortic pressure. If you are doing the aortic pressure, then the bleeding will be less and you will be able to see it. The other thing is you can ask your assistant to pull the uterus up.
Okay.
Okay,
Sorry,
ma'am.
to pull the uterus down, not
Down.
up. So
Push
if
it down.
push it down, then the cervix is more visible. But for vaginal tear, it is good to push it up so that you can see the apex of the vagina. For cervical tear, when you push it down, then you can see the cervical tear more clearly, and this aortic compression will decrease the bleeding and you will be able to visualize the tear more clearly and stitch it.
Dr. Meenakshi,
Agree.
I have seen in my own time that the apex is felt by the index finger, but when I'm visualizing, it is not it's not that visible. So what is your suturing technique? Usually, ideally, we should start from 1 centimeter above the apex so that it doesn't retract. By chance, apex is not visible. Do you straight away will want to go for laparotomy, or you will start suturing from below and then you will try to reach the apex by pulling the uterus down? What is your technique in this? Dr. Meenakshi? I think anybody can take that
Can I
question.
add? Can I add? Hello?
Yes, I would like to start from below and then pull it, and maybe I'll see the apex. Many times I've done it.
Absolutely, ma'am.
And if you still can't reach it, then of course you have to go in for laparotomy.
Right.
But most of the times we can, especially when you push the uterus a bit lower, then you can may be able to reach the apex.
Yeah, a lot of time one can see that when after a prolonged delivery, obstetrical delivery, or after long prolonged labor, we find that the anterior cervix is black. Until as soon as we try to hold and look at the cervical angles, then it might get teared off. So this happens a lot of time, but there is no bleeding. So in those such small tears, we need not to do anything. Even small tears at the lateral angle also, we need not do anything unless it is bleeding. The small
We
tear
can
more
just
than
do vaginal packing in those
yeah.
cases.
And important thing is that you have to tilt the table. Head side should be slightly down.
Yeah.
Only then the light will reach there and you will be able to catch the apex properly.
Yeah, yeah.
Sir, here, ma'am, comes the role of good light and good assistant, ma'am.
Good
Yeah,
assistant and
assistant
good
is very
table movement.
important.
Yes,
Assistant is very important.
Good light and good assistant. Yes, ma'am.
Yeah, yeah.
Madam said absolutely right that we put one suture prior and then we keep on pulling and going up. This is the technique which we have followed.
Right. Vinita, would you like to take the third scenario?
I think you continue. I'll take the last part of it. Don't worry.
Okay. So we have another patient who is 30-year-old, gravida 2, abortion 1. For abortion 1, DNC was done 8 weeks because she was missed abortion. This was 6 months back. Now she delivers spontaneously. But on examination, the placenta seems incomplete. A part of it is still inside the uterus. She develops continuous moderate bleeding, and ultrasound definitely shows echogenic fragments in the uterine cavity. So what are the high-risk factors for retained placenta? Dr. Dinesh?
Any other panelist who has joined but not answered, please, we cannot see who has joined. Dr. Ruchi, Dr. Preeti, Dr. Anupam.
Any scar over the uterine cavity, uterine cavity, because of the previous cesarean section, dilation curettage, can lead to such case of retained placenta because of the placenta acreta or syndrome. So if they small, there might be partial when they get adhered and they not get detached while getting delivered. So we have to always keep such thing in mind when you are After the patient is delivered, we look it in toto so that we realize that is whole percentage expelled out or not.
So how would you manage this patient of retained placenta?
First of all, the most important thing that we arrange for blood immediately. So if once we know that they retain placenta, if we immediately arrange blood and ask our OT to make ready, and we'll shift the patient to OT and do a Dalton curettage. If possible, we have to go for uterine curettage again. If we suspect that is not because of the DNC or previous DNC, no history of previous DNC or no scar. Otherwise, we can do manually if try. If not possible, then we have to go for laparotomy and manage the case.
All right. So this is just few words on how would we manage the third stage of labor. We give oxytocin, the CCT, uterine massage, high risk identification. We have to be very careful of severe anemia and shock in the patient. So the last case, Vineet ma'am, will you like to take coagulopathy or I'll go ahead?
Okay, I'll take this case. Any panelist or any faculty wants to have a word on the previous cases, please go ahead. Okay, now I come to the last case, that is a 35-year-old female with severe preeclampsia, develops PPH, and despite uterotonics and a firm uterus, bleeding is still continuing. And lab shows low platelets and prolonged clotting time. So Dr. Sangeeta ma'am, how will you diagnose that she is now a case of that fourth cause, that is a thrombin or coagulopathy? Dr. Sangeeta ma'am, are you there? Any of the panelists can take that?
So bedside CT CRT, bleeding time CT CRT can help in diagnosing this condition, as well as I mean CT CRT itself is going to take a long time. CRT at least is going to take a long time, but BT and blood bleeding time and coagulation time can be checked. That itself shows, and any prick from the any prick or any cannula sites which are oozing, that also shows that yes, probably the patient is going into DIC. So those are the basic bedside tests, point of care tests that can help us identify the situation. So the first thing here would be that when we've seen that there are low platelets and we need to
high risk preeclampsia, yes.
Yeah, so we need to give component therapy. We have to give platelet transfusion, as well as in these cases, because of consumptive coagulopathy, there is a possibility of decreased fibrinogen levels. Cryoprecipitates in such a case would be the best bet to decrease this bleeding. Any temporizing measures, for example, even balloon tamponade in such cases, in case we find, because the things get linked. Once the patient is in DIC, the uterus will also tend to become atonic. There will be bleeding. So we try all measures to control the bleeding as well as build up the patient simultaneously with blood component therapy.
Yes, ma'am. Very true. Next slide.
Even PBF is very, very important. I would like to add peripheral blood smear is very, very important to rule out the coagulopathy. To see for the thrombocytopenia and even the fragmented RBCs we can see in the PBF.
So once you are sending the sample, at least ask them to go for PBF also.
Yeah.
So as we discussed, like atonic PPH can occur not in alone, but in a case. So, can I resume? So, Dr. Bharti, can you please continue, because this is one case which can be like as you said, that once we are dealing with the DIC, so the tone also tends to reduce, and there is a possibility that that other factors may also be there. So, would you like to elaborate on this, ma'am?
So I believe in such cases, the patient is already in DIC. She is delivered vaginally. So our best bet is to minimize the trauma that we cause. So managing her through compression, the bimanual compression till we arrange for the balloon tamponade, and simultaneously resuscitating the patient with blood and blood products is the best bet that we can do. At that time, when a patient is in DIC, tranexamic acid itself will not be effective. In such
Yes.
cases, it won't help. So that is giving uterotonics has to be, we have to give uterotonics and ensure that the uterus remains contracted or at least compressed. We may have to, we have to resort to massive transfusion protocol in such cases. If the patient continues to bleed, then we have to give rapid blood transfusion, but keeping in mind that the ratio of the blood products that we are giving is 1:1, because otherwise just the PRBCs will cause dilutional coagulopathy also. It will lead to decreased platelets as well as decreased fibrinogen. That is why we'll have to give cryoprecipitates as well as platelets along with blood.
Next slide. No, the previous one.
We have to correct acidosis also. These patients they are progressively moving towards that lethal triad of coagulopathy, acidosis, and hypothermia. So all these conditions have to be taken
I
care
think this is not in the question, but I just need to ask senior faculty, when the patient is going into DIC, so role of peripartum hysterectomy in those cases?
Ma'am, what's the question?
I was not. Any role of peripartum hysterectomy once the patient is going into DIC, like in the third case? Anybody can take it?
I think we should be doing it because otherwise patient may continue to bleed. This should be done along with correcting the coagulopathy.
So everything has to be done simultaneously.
Yeah.
Dr. Dhaliwal, ma'am. Dr. Mohi, ma'am.
Hello.
Yes,
Actually, yes. Actually, Vineet, this will depend. Coagulopathy is something which is going to be treated by giving the components and the blood and the fibrinogen. Yes, if you have already opened a case, it depends. Only there you will be planning to do for the peripartum hysterectomy. If the patient has delivered, say baby because of abruptio placentae, I do not know this case, then you will not be opening a case. Depending upon it, depending upon whether you are already cases opened or not. If it is open, definitely you will be planning to remove the uterus and to save the patient. Bleeding has to be controlled, but mainstay remains at replacement therapy, component therapy, and the proper management.
Because otherwise it will act as a double-edged sword, ma'am.
Definitely.
May I say something?
This is absolutely case to case
Continue,
variations. Because just recently I had a patient who came to me with the grade 4 abruptio placentae. We did her cesarean, we delivered the baby. It was a cavalier uterus, but she went into DIC. We closed the uterus, we gave the components and the blood, and she was saved. We did not do the hysterectomy because we wanted to save the time. Uterus was contracted, it was not bleeding, only DIC component was there. So it depends case to case.
Thank you, ma'am. I think
may I say something?
We will close with the rapid fire to all the panelists and all the faculty.
Dr. Kala, please. Dr. Kala, please continue.
I wanted to tell you the patient got DIC. Please don't do any surgical treatment, because if she has got DIC, she is not going to bleed from the uterus, but she is going to bleed from every
That is why I asked this question, ma'am,
Yeah,
because the
you
role
just
of
treat
in DIC.
her with clotting factors. I told you just now that we had a patient who had DIC and we gave 28 units of fresh blood The whole night we were all awake and we gave it. So in the morning she recovered. Because all the clotting factors are in plenty in the fresh blood. We did not have any other thing to do, anything. We have no fibrinogen, no EACA and all that. So we had to depend only on the fresh blood. And we saved her. Not I, but God saved her. No other surgery, no hysterectomy, nothing of the sort. Just don't touch her. Plus, correct her DIC. Understand?
Yes, ma'am. Yes, ma'am.
Absolutely, ma'am. Absolutely. This is the way we did it. Actually,
Can
ma'am,
we come
28
back?
years back, actually,
Dr.
ma'am,
Vineet, I
28
want to
years
ask
back,
one question.
component therapy was not available. Now component therapy is available. So we can give each and everything separately.
Yes.
And I think even fibrinogen is available.
Ma'am,
as
factor
well.
7 is available.
Yes.
Factor 7, and I have
asking
given
about that,
to my
yeah.
2-3 patients factor 7 and I have saved them. Definitely it is costly, but it is not more than a patient's life. It is available at Kumar store, and we have given, I think, to 3 patients.
What is the
and they
name?
have saved.
What is the name
Manjeet,
of the
ma'am. Manjeet.
name of the product?
Ma'am, factor 7.
Factor 7.
Factor 7, ma'am. You
factor
just
7.
write down. Recombinant factor 7.
Yeah.
What is it?
Recombinant factor 7.
Okay, okay.
Yes,
No.
ma'am. Yes, ma'am.
And
We're
even
giving it.
When we didn't have
Good.
components, we were depending mainly on fresh blood.
Fresh blood. Yes.
Yeah.
Yeah, and I think fibrinogen, if we give, then we can save some of our.
When military hospital was here in the neighborhood, then we used to get fibrinogen from there.
It's available in the market,
Now,
fibrinogen.
now it may be, but at that time, beta, we were, क्या बोले मैं? Very
Time has
primitive.
changed, ma'am.
Very
But time has
primitive
changed.
time. We were working in very primitive areas. Working in primitive.
Yeah, Kala, I'm older than you.
Who?
Dr. Sareen.
No.
So, yeah. So we have faced almost the same scenario.
Older than me.
Me?
Dr. Sareen is older than you.
Yeah.
Dr.
I'm 2
Sareen is
years
older
senior
than
to
you.
you.
Dr. Sareen, yes, 1
Yeah.
year only, not more than that.
2 years senior to you. Kala, I was 2 years senior to you.
But I was 1 year, my father gave the date of birth 1 year
Yeah.
later.
Oh my
Okay.
I is only 1 year junior to you.
Okay, done. Accepted.
Okay, ma'am.
So
I think
MH से लाते थे हम fibrinogen.
Fibrinogen is easily available.
I think on that note, I'll give the carry home messages. We are done with the rapid fire. Next, Natasha. So, Natasha, can you please summarize the whole panel?
Dr. Vineet, I want to ask one question. Dr. Vineet?
Okay, ma'am. Okay.
Hello?
तभी तो
Yeah, I want to ask how you people used to measure the blood loss. This is my question.
बड़ी अजीब है.
Hello?
Kidney tray.
Voice is like
We used to put the kidney
voices
tray
at
in
the
front
same time.
and measure the blood loss. We used to have a special sheet for the patient. It was plastic, a round thing, and the blood will drain and we will put on the kidney tray. And a kidney tray will contain about 500 ml.
बार-बार मुझे कहना कल तो परसों तो पैसे दे दो पैसे दे दो पैसे दे दो मैं नहीं दूंगी परसों दूंगी ना ना कौन जो मर्जी कहे मैंने पता कल होली है उन्हें आज शराब पीनी है
Hello, ma'am.
हेलो बेटा
Hello.
सॉरी अनम्यूट करती हूँ अनम्यूट करती हूँ
Natasha.
अनम्यूट कर दिया।
विनीत बंद करो अब मीटिंग।
हाँ जी
काफी हो गया।
मैं कर रही
Okay,
हूँ,
okay.
Natasha is not able to, okay,
हाँ
I'll
जी।
take the call. Okay, and I think on that note, we summarize that any woman who is birthing can have PPH. Chances are as high as 1 in 4, and more than 300 ml with blood deteriorating vitals or anything more than 500 is now PPH. And remember that PPH is preventable and use consistent protocols for that. And call for help, call for your team, and apply active management of third stage labor, that is 10 unit oxytocin or heat stable carbetocin or misoprostol, and follow the motive bundle. If PPH is there, ensure that tranexamic essay is to be given within 3 hours only. And uterine balloon tamponade, suction cannula, lab profile, and bleeding time. And IV line, of course, the management is simultaneously going on. So IV line with 2 wide bore cannula, very important. Wide bore cannula, and rush the crystalloids and follow proper referral protocol. And thank you so much. Thank you so much. And now I please the coordinators, the program coordinators, please take over from here. Thank you so much. And it was such a nice panel. I thoroughly enjoyed. Thank you.
I am sorry, Vineet, that I was could not get in touch in the.
Are the organizers there, coordinators? Please.
Yes, ma'am. Yes, I'm there, ma'am.
Dr. MC Patel, your last words of wisdom.
So do you want to give any concluding remarks?
I think, ma'am, up. You take
Yeah,
over.
I think it is also very important, Vineet, that we should know how to care them after PPH.
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Monitoring is very important.
Monitoring is important. Then when to discharge home, what to give when they go home, and the follow. That's very
And on
important.
discharge, the proper documentation of what all has happened in this particular pregnancy is very important.
Yeah.
So that whenever she goes to any other hospital, she should have a record of
post-delivery or post-operative counseling is equally important.
Yes.
What was happened, what we have done, and what could be future consequences, and which kind of special care she has to take as per our advice. Everything should be well counseled even after all this episode happened.
Also, risk of secondary PPH should be explained. Yes. Yes, ma'am.
I didn't touch secondary PPH because we all got so much involved in dealing with these cases. So secondary PPH, I think we will have another panel on that.
No, but patient who has primary
Yes, ma'am.
also is at the risk of secondary. So she should be told to watch the bleeding.
Yes, ma'am. Yes.
I think that's important.
Yes, ma'am.
And the other thing I would like to add here is that many patients, especially at our centers at Patiala, just as soon as they deliver, they are ready to go home. So it is very important, even if they didn't have any complications, that they should stay in the facility for 24 hours. If they want a discharge, it should be discharged against the medical advice. And WHO recommendations also say the same.
Yes,
that they should be in the facility even if they had no complication for 24 hours.
Patel sir, can we now conclude?
Oh, yes.
Yes, sir. A very big thank you to Amritsar, Chandigarh, Faridkot, Firozpur and Patiala societies for joining us today for the 222nd episode of the Happy Learning webinar series with program director as Dr. MC Patel sir. Our coordinator for today, Dr. Vineet Nagpal ma'am, thank you so much for all the help across the program. Our chief guest, Dr. Ashi Sareen ma'am and Dr. Madhu Nagpal. Our guest of honor, Dr. Kala Vashish, Dr. Parneet Kaur, Dr. Umesh Jindal, Dr. Amritpal Dhillon. Our first speaker, Dr. Deepa Goyal, and the second speaker, Dr. Lakhbir Dariwal ma'am. Thank you so much for your excellent inputs. Our chairpersons, Dr. Sarabjit, Dr. Monica Narang, Dr. Preenvit Kalsabia,
Dr. Renu Chakravarti, Dr. Rimi Singla, and Dr. Rashmi Bagga. Our chairpersons for the third session, Dr. Yashpala, Dr. Manjeet Kaur, and Dr. Jagdeep Singh. Thank you for sharing the sessions and your inputs after the talks. Our panel discussion was none less than the cherry on the icing of the cake. Dr. Vineet Nagpal and Dr. Natasha Gupta, with our experts, Dr. Riti and Dr. Alka Sehgal, have given all the practical take-home tips for managing the postpartum hemorrhage. Our panelists, Dr. Dinesh Pathak sir, Dr. Sangeeta Pava, Dr. Preeti Jindal, Dr. Anupam Goyal, Dr. Manisha Jain, Dr. Meenakshi Rohila, Dr. Ruchi Rai Ahuja, Dr. Mangla Dongra, and Dr. Jalpeen Kaur. Thank you for your inputs. I'm sure that the delegates have had a feast today. Nonetheless, thank you to all the delegates who have joined us online today and Corona Remedies for the academic platform. Wishing you, sir, all the very best for all the future for Foxy endeavors and requesting all the participating societies to please support candidature for sir for the upcoming elections as presidential candidate. Thank you, everyone, and happy Holi to everyone.
The Punjab is there with you.
Oh, yes, thank you.
We are always with you, sir.
Oh, yes.
Thank you, everyone. Yes.
Thank you.
In Corona, we can end the meeting today.
Thank you.
A
Yeah,
lot of
thank you.
big
Good
happy
night.
Holi to everyone. Safe
Happy
Holi.
Holi to everyone.
Thank
Happy
you.
and safe Holi.
Thank you.
Thank you. Thank you.
MC sir, now plan for the visit.
Oh, yes.
ठीक है सर, थैंक यू.
नहीं, दो पार्ट में
Okay.
पंजाब आना है.
ठीक है सर, थैंक यू.
Okay.
Thank you, Sareen ma'am. Thank you, sir. Thank you, Kala ma'am.
Okay. Good night.
Good night,
Good night.
ma'am.
Good night.
Thank you.